are live now.
Good evening, everyone. I'm Dr. Maunika from Shield Healthcare. I welcome you all for today's session amongst Medical Disorder Committee with Ahmedabad, Anand, Nadia, Navsari Societies of Gujarat. And our topic is hypertensive disorders of pregnancy. So before starting the program, I would like to invite all the dignitaries for lamp lighting and play invocation and prayer video.
Kurutvang kalyanam arogyam dhanasampadam Shubham kurutvang kalyanam arogyam dhanasampadam Shatrubuddhi vinashaya Deepajyotirnamostute Deepajyotirnamostute Shubham kurutvang kalyanam arogyam dhanasampadam Shubham kurutvang kalyanam arogyam
And I welcome Dr. Sneha Boyar ma'am and our conveners Dr. Archana Dwivedi and Dr. Kirtan Vyas and our MOC Dr. Munjal Pandya. I hand over this session to Dr. Munjal Pandya.
I think Madam Munjal is stuck
Yes,
with some
Munjal
emergency.
is not.
Yes,
I can't
yes.
see him. You can take a.
Yes, madam. So I take this privilege to invite all our dignitaries and all the audience to welcome to this wonderful academic session. And we have with our respected Dr. Rishikesh Pai sir, Dr. Pardesi sir, Dr. Suchitra madam, Dr. Kuldeep sir, and all other dignitaries. So I welcome on behalf of AMOGS to all of you. And I take this privilege right now to introduce our very dear Dr. Sneha Boyar madam for her introductory session. Dr. Sneha Boyar has a very great academic career right from BJMC Pune. She has been awarded with so many awards and accolades right from Foxy as well as AMOGS and other organizations. She has to her credit so many talks and publications in different index journals and different chapters in textbooks. She has been the past chairperson of Committee for Female Breast by Foxy, and presently she is the chairperson for AMEJS Medical Disorders Committee. So, madam, we welcome you all, and I invite you for the introductory session, madam.
The main highlight, I would like to say that Madam is contesting for the VP elections this year very soon. So we need to wholeheartedly support her also.
Yes, absolutely.
Yeah. So thank you so much once again. A very good evening to respected chief guest for today's function, Foxy President Dr. Rishikesh Pai and past President of Foxy, Dr. Alpesh Gandhi, amongst President Dr. Rajendra Singh Pardesi, amongst Secretary Madam Sujata Darvi, my mentor Dr. Suchitra Pandit, our dear friend Dr. Girija Wagh, Dr. Kuldeep Singh, all the presidents and secretaries of Ahmedabad, Anand, Nadia and Navsari societies, all the esteemed faculties, the chairpersons, all my conveners, Dr. Kirtan Vyas, Dr. Archana, and my MOC for today, Dr. Munjal Pandya, all the esteemed faculties, all of you, I welcome warmly here for this program. I just want to share with you all that as a chairperson of amongst Medical Disorders Committee, I've been working from all the medical disorders of pregnancy, and since I have taken over almost all states, we are reaching every society. With my experience of 3 decades of experience of my high-risk obstetrics practice, I have realized that there are so many things we can predict, we can prevent, we can diagnose at the earliest, and we can be prepared to tackle the situation as well. And so I'm thankful to my AMOGS president for shouldering me this responsibility. I take this opportunity to welcome all of you. Welcome Dr. Gorak Mandrupkar, our dear friend, who is going to moderate a panel with me. With this, I request Dr. Rishikesh Pai, who is the FOXI president at present and president of so many organizations. Sir is a very illustrious person with a highly decorated CV. He's the founder and medical director of Bloom IVF, and sir, lots and lots of awards and accolades. Time will fall short, so we are very eager to listen to your precious words, sir. So over to you, Dr. Rishikesh Pai.
Thank you very much. I'm in the on the return flight from Cape Town, where we are representing FOXI, our lovely organization. And there is this. So I would like to pay my respects to all of you here, Doctor. Of course, Neha Boyar is doing the whole program, as well as the conveners Archana Dwivedi and Kirtan Vyas, and our own AMOX president, Dr. Pardesi, past president Suchitra Pandit, Alpesh Gandhi, Kuldeep Jain, and many other, Kuldeep Singh, and many other who are there, but I can't see. Basically, the two important things that have in this conference, the two objectives are the INAP and EPMM. The INAP is every newborn action plan, and EPMM is ending preventable maternal mortality. These are the two action plan of the Align MNCH, is maternal and newborn child health. MNCH. That's the conference, and all the major organizations of the world, including WHO, UNICEF, UNFPA, Bill Gates Foundation, USAID, and supported by Japan, all of them have aligned themselves for this. I had also gone recently to the Bangkok for the family planning. So all the goals of the 2030 are being, charted out, and obviously our country is doing very well in this goals. We have reached our goals beforehand mainly because of the private and public participation. Government of India and the state governments have also been very active, as well as the private organizations, including our AMOX and all the state organizations and our federation. We are all very good people. We are all focused in helping our patients, and no one can challenge our goodness. So basically, we are all good. We always believe we love our patients, and one of the important 3 preventable maternal parameters to prevent maternal death is PPH, sepsis, and hypertension, and abortion-related death. So now the whole focus at present is on PPH. They are all obsessed with PPH at present. So that's the obsession. And one of the biggest emotive trial has just taken place here, where they have collected the blood of the, when they deliver, there is this collection system which is being done by our own Indian company, excellent, from the south, and you can predict whether PPH is occurring by, as soon as it crosses 500 ml in the collection system, you start on misoprostol, oxytocin, and tranexamic acid, and they showed a 60% improvement in the New England Journal. This was the main study which was presented at this conference, and there was so much effectiveness that they stopped the trial. They stopped the trial, and instructions were given to immediately institute it all over the world. So this is the biggest thing that has come from this conference. So anyway, what the FOXI has done as a FOXI president, I have become slowly maternal health person rather than IVF person. So that is because ultimately maternal health is what counts. I do not take much of your time. Shreya, all the best to you and your future endeavors, and wish all of you the best. And so many plans are there in my mind when I come back. I don't know when I'm going to get time to sleep. So many things I have to put into action. So many parameters are there. So many areas which all of us have to collectively work. See, we have to align. See, what is the meaning of this conference? Alignment. Unless we don't align, we'll not be able to be effective. So it's very important to align with each other. That's the name of the game. And yesterday in the talk, I told them that most important thing is inclusiveness. See, all our organizations are pyramidal. Means there is a top man who controls everything. That is the president. But we have to also be cylindrical. Means at the top, there should be many people controlling the organization. Then only continuity will be maintained. And that is what I did in the Manyata program. I created what is known as the main committee, where I took all the precedents so that the continuity was maintained. Any program, if you want that program to sustain, you have to give ownership to the past presidents and the future presidents. Then only the continuity of the program will be maintained and we can create impact of the program. So this is what I told them. The leadership is the most important. There are 3 A's: approach to the problem, the first is. The second is availability of good care. And the third is the accessibility to that availability. All 3 A's are need to be aligned to achieve the ultimate effectiveness. So anyway, thank you very much, Sneha, for calling me. I'll sign out now. I'm climbing the stairs, but I'm very excited and I hope we can achieve more things. We have done a lot of plans. We have got a lot of research projects. All the GCPRs are in the final process of implementation, and new GCPRs I'm adding, nearly 20 new GCPRs I'm adding to our Foxy. So I need all your help of all of you who are there for future effective implementation. See you. Bye-bye.
Bye-bye, sir. Thank you so much for your very precious words of guidance, sir. And definitely, as you said, hypertension, hemorrhage, and sepsis, these are the 3 major killers. And PPH is on priority. We would like to contribute to it, definitely. With this, I thank you once again, and I welcome Dr. Alpesh Gandhi, sir, today's chief guest, for his precious work. So it has been a very proud year for me to work with Dr. Alpesh Gandhi, the visionary president of Foxy. In spite of the difficult times of COVID, sir has worked it right from adolescence to menopause and the benign diseases to the malignancy, of course, the obstetric emergency. And sir has covered the public, general public, along with the Foxians and even the parents. So I would say the best possible work sir has done, along with his very highly illustrated, very well decorated CV. I just want to listen to you, sir, your precious words. Over to you, Dr. Alpesh Gandhi.
Thank you, Dr. Sneha, for the kind words, generous introduction, appreciating the work done as the past President Foxy. It became possible because of the support from all the Foxy members and all the committee chairpersons, like one of them was you also. And it was also possible because of the support from all the office bearers. It was a great experience to work for Foxy along with you, all of you. It was good to know, good to listen, opinion, views, vision, and work done by our present President, Dr. Rishikesh Pai, today's chief guest. I would like to congratulate Dr. Rishikesh for the extensive work he is doing as the Foxy President this year and his team Badlao. I would also like to congratulate AMOX and its medical disorder in pregnancy committee for the good work, good academic work they are doing. I'm observing since long. So I would also like to congratulate my dear friend, Dr. Rajendra Singh Pardesi, for the good work. Since long, I know him and since so many years, he's doing very, very good work. And of course, Kiran Kurkuti, all the team of AMOX and the committee, medical disorder in pregnancies, also doing very good work. I have seen working Sneha since so many years. I can say since nearly 12, 13 years minimum. And I have seen she's very passionate for her work, doing very good work. Particularly, she is very, very interested for the high-risk pregnancy, critical care in obstetrics. And of course, in Foxy, in her committee also, she has done a lot of good work, lot of initiative work, and particularly also for the social so many national and international days we celebrated. So a lot of good social work is also she is doing. She has done a work, I would say, during my tenure. I was fortunate that all the committee chairpersons were doing so much good work that it was difficult to say that who which committee has should be given the best committee award. But of course, your committee was one of the strong committee who has done work equal, we can say, like best, one of the best committee of Foxy. Coming to today's topic, you have rightly chosen a very important topic. Hypertensive disorder in pregnancy is a very important topic. We can say our now priority is SDG goal, which is to be achieved by 2030. But I would say, being the main stakeholder of women's healthcare in India, our vision should be that our maternal mortality rate should not only achieve SDG goal, but it should become equal to developed countries, means below 20. And this should be our vision for the next 10 years. And it is good that we can say now 10 states in India have already achieved SDG goal. So if we want to achieve maternal mortality rate equal to very developed world, below 20 or below 30, then our prime aim should be to follow each and every high-risk pregnancy. And when we are talking of high-risk pregnancy, always HTP is number one in our mind. Still, across at present in India, nearly more than 500 HTUs are working. But if we look at the performance and if we collect the data, then we found that HTP is number one indication for the admission in obstetric HTU across the country. And the sad part is, across the world, the incidence of HDP is increasing, maybe because of the increasing incidence of obesity or diabetes mellitus or so many other reasons, maybe because of the elderly pregnant woman, maybe because of the environment, so many other reasons are there. But the fact is that incidence of HDP is increasing. And that is why it is very important for all of us to update ourselves. And that is why it is also very important. Since so many years we are trying to predict and prevent HDP. So it is very important to know about the prevention, about the prediction, about the management, about the complications. I would not go in detail of all these complications. We know there are a big list of the complications. It's a multi-systemic disorder. It can lead to many complications of many systems. And that is why it is the number one indication for the admission in HTU. So I am happy that you have selected a topic which is very important for today's modern obstetric in our country. And you have a panel of galaxy of faculties, so many like Dr. Girija, Dr. Gorak, yourself, Dr. So many Gupta, so many are there. Suchitra madam. So all, and we all are also working together in Justices for the same reason. So I would say the best faculties across India you have invited for this purpose. So our delegates will be benefited a lot. So my regards to Dr. Suchitra, Dr. Girija, Dr. Professor, Dr. Gorak, to you and all the faculties. And particularly, I am happy that this time this program is amongst with 4 societies of Gujarat. My own society, Ahmedabad Society, is participating. So I would also like to congratulate President and secretaries of Ahmedabad, Anand Nadiyad and Navsari Society for joining for this very important webinar. And I wish grand success to this webinar, and I also my best wishes to you also for all your future endeavors. Thank you very much for inviting me, giving this opportunity to share my views as the guest of honor. And please continue the good work. Thank you very much.
Thank you very much, sir. Alpesh sir and Pai sir.
Thank you, sir.
Yes.
Thank you so much for your words of appreciation.
Yes,
And
my hello to my friends Kirtan, Munjal, and Archana.
yes, so
thank you very much, sir.
Thank you for the acknowledgement, sir.
Yes, sir.
so
It is always good to be around you, sir.
Yes.
Whether in Ahmedabad directly or by this meeting even.
It is good for me to become to be around with all of you.
Pleasure is ours, sir, and I would
Yes.
like to request Neha ma'am to welcome our ICOG and MOX presidents and secretary and acknowledge their presence. at this point.
for your words of appreciation and your as the women's health is
I think Sneha ma'am's network is lagging. So I would invite Dr. Rajendra Pardesi, sir, to give a few words. Madam's back. Madam, unmute yourself.
Good afternoon, everybody.
yes.
Respected DIAS dignitaries.
Hello.
and DIAS.
Yes. So yeah, sir.
No, it's okay, Sneha.
It's-
Just we can skip our data by data. First, I wish to congratulate Dr. Sneha Buyar, our ever active, ever smiling chairperson of AMOX Medical Disorder of Pregnancy, for organizing such an important health webinar on hypertensive disorders of pregnancy. And that is in association with Ahmedabad, Anand, Nadiad, and Navsari Society. I am very happy to joining with the hands with the Gujarat societies for this initiative to spread knowledge and awareness. I wish every success to Dr. Sneha Buyar for her future endeavor in FOXI as Vice President. We need like Sneha Buyar in FOXI. I wish every success to this great event on hypertensive disorders in pregnancy. Thank you. Thank you so much for inviting me. Thank you. Thank you.
Sir, thank you so much for your blessings. In fact, initially itself, I've said as a hardcore obstetrician, you have given me this opportunity to take this good work ahead. And I'm very much thankful to you, sir. I need your support always. Thanks for your blessings. Now I invite Madam Sujata Davi, the Secretary of AMOX, a very genuine and humble person. Madam has got such a illustrious CV, but I would request Madam to deliver her address and of course a few words of guidance to us. Over to you, Madam Sujata Davi. Madam, please unmute yourself. Please unmute. Yeah.
Now? Yeah, okay.
Yes.
So thank you, Sneha, for a very kind introduction. On behalf of AMOX, as a secretary of AMOX, I would like to express my gratitude to President of AMOX, Dr. Rajendra Singh Pardesi, for always encouraging such scientific program as such. I would also like to express my gratitude to AMOX Medical Disorder Committee, Dr. Sneha Buyar, who's always so academically oriented, and she arranges so many of these programs. And this time today, the program is along with OBGYN Society of Ahmedabad, Anand, Nadiad, and Navsari societies. And this is in view of the World Hypertension Day that she has arranged a program on hypertensive disorders of pre-eclampsia. I would also like to express gratitude to the conveners of today's program, Dr. Kirtan Vyas and Dr. Archana Trivedi. And today's speakers are excellent so far as their academics in hypertensive disorders in pregnancy is concerned, and they would give a very good message to all those who have logged in. I would like to express my best wishes to Dr. Sneha Buyar for her future endeavor in FOXI. Thank you so much, Sneha.
Thank you, Madam. Thank you so much. Over to you, Kirtan and Archana.
Madam, I would like you to express our regards to ICOG for including ourselves in this session.
Yes, with this, I just express my gratitude to today's chief guest, Dr. Rishikesh Pai. Dr. Alpesh Gandhi, and AMOG's President, Dr. Pardesi sir, and Madam Sujata Dalvi, my mentor, Dr. Suchitra Pandit, my dear friends, Dr. Gorak Mandrudkar, Dr. Girija Wagh, and Dr. Ajay Mane, all the President Secretaries of Ahmedabad, Anand, Nadiad, and Navsari societies, all the esteemed faculties and delegates. I would like to put it on the record and thank the ICOG chairperson, Dr. Lakshmi Shikhande, and the secretary, Dr. Ashok Kumar, for granting 2 credit points for this program. And with this, we thank all of you for your blessings, and we declare that the academic session should be started soon. Over to you, Archana. Thank you so much.
Ma'am, and we really had the blessings of eminent dignitaries on this dais, and yet welcoming for the first talk, the epitome of strength and knowledge, we have Dr. Suchitra Pandit Madam, and it's my pleasure to invite the power duos from Ahmedabad, Dr. Mukesh Savalia, who is the current president, to chair the session, sir. He's been practicing since 25 years in Ahmedabad, Bapunagar Janta Pageantry Hospital. And along with him, Dr. Jignesh Deliwala, who is the past president of UOGS. And we had a great academic feast during ISOG 2017 with Alpesh Gandhi sir also here. So I invite you all both to chair the first talk of Dr. Suchitra Pandit. Over to you, Dr. Mukesh sir. Sir, you can unmute
Mukesh,
yourself.
yes, please, Mukesh sir.
Mukesh sir, please unmute yourself.
Please unmute yourself.
Good afternoon, everybody. I invite Dr. Suchitra Pandit Madam for their speech on the prediction of PI. All of you must be knowing that since long or since the practice, we all are looking for the screening or whether we have any marker for the prediction of PI, a huge problem. Let us see what Madam says about that. We have evaluated so many markers right now up to until now, but still we are lacking 100% prediction of PIH. Now, let us see what Dr. Suchitra Pandit Madam says to us. It is over to you, Madam Pandit, for the next talk.
Thank you so much, Dr. Mukesh. I'm sharing screen. Is it visible? I just want to check that.
Yes, madam.
Yeah. Is it full screen?
No, ma'am, full screen karna padega.
Acha. Just a second. Just half a second, and I'm just going to check it. Share screen. Yeah. Okay.
Yes, madam.
Yeah. Okay. First of all, thanks, Sneha. A wonderful initiation. And it's good that you've involved the AMOGs along with the, all the Agestosis organization also. And thanks to all the dignitaries who have spoken before, including Rishikesh Pai, Alpesh Gandhi, Sujata, as well as Rajendra Pardesi. And wonderful, first of all, also congratulations to Mukesh Savalia for taking over. In fact, I was present at your, when you were taking over. I had come with Alpesh Gandhi, but couldn't personally congratulate you. So Dr. Mukesh, congrats for taking over as president. So the topic is updates on prediction and.
Thank you.
Yeah. So HDP, as it's now called, it's a complete, complex and clinically challenging group of pregnancy complications that are leading cause of maternal and perinatal morbidity and mortality worldwide. And we know it affects 10%, preeclampsia affects 3 to 5%. And the term HDP includes preeclampsia, eclampsia, gestational hypertension, and chronic hypertension. And we know today that we are number 2 as a direct cause of maternal death. And obviously, preeclampsia is such a widespread vascular endothelial problem. The vasospasm that occurs after 20 weeks is rightly caused as preeclampsia and can present as late as 4 to 6 weeks postpartum. But today we also know that when you're talking about the definition, there are many cases who have high blood pressure, but who do not have any proteinuria and yet can manifest the multi-organ problems. And therefore, the previous definition which included preeclampsia means high blood pressure plus proteinuria. The newer definitions do not include proteinuria as a must for the diagnosis. But what we must remember is beyond diagnosis, there is a high unmet medical need for better, reliable predictive markers, because how should we improve the fetal and maternal outcomes and reduce the unnecessary hospital admissions? So plenty of research work is being done on this. But remember, whenever we are talking about a screening test, it should be cheap, available, reliable, and reproducible. And because if you have a good test, then we will be able to do a closer surveillance and have earlier interventions to improve outcomes. So the first foremost I would like to talk about is the Gestosis score, which is being devised by the Gestosis core group. And we have Gorak, Dr. Sanjay Gupte, Girija Wagh, and Alpesh Gandhi, including myself. And Gorak has also developed the Gestosis app. And it has already been validated by 2 centers, and the study is published in Jogi 2022 by Meeta Gupta. And I'm sure that when we talk to you about the Gestosis score, you'll realize that though we are talking about maternal factors, here is a comprehensive analysis where you're looking at evidence-based risk factors. So when the patient comes to you for the first time, start looking at these factors, which you can actually access through the app from the Android phone. So if there's an age lesser than 19 or more than 35, merits a score of 1. Obesity, the BMI is between 26 and 30. Primies, obviously. Maternal anemia, short duration of paternity. Women born as small for gestational age themselves, sometimes we may not always be able to elicit this history, but at least ask for it. If the mean arterial pressure is more than 85, chronic vascular disease, PCO today, which is on the rise, interpregnancy interval of more than 5 years, and excessive weight gain during pregnancy, and if the woman is conceived with ART, IVF, or ICSI, all these merit a score of 1. But if there's a maternal hypothyroidism, a family history of preeclampsia, gestational diabetes, obesity, BMI more than 30, or if there's a multiple pregnancy, or if there is an HDP during the previous pregnancy, it gets a score of 2. But if the patient is already diabetic prior to conception, chronic hypertensive, inherited or acquired thrombophilias, mental health issues, maternal chronic kidney disease, and ART where you're looking at ovum donation or surrogacy, then it merits a score of 3. So at the first visit, when you're taking a history, just allocate the points. And if you have 3 or more, it means that this patient is marked at high risk for preeclampsia. And at every visit, you can keep doing this score. And if you feel it is getting upgraded, start off with the low dose aspirin. The preventive measure is in the form of low dose aspirin, 75 to 150, started along with calcium 1 to 1.5 grams, particularly in the low calcium intake group, as early as possible, right up to 48 hours pre-labor, induction, or up to delivery. And this is the app which I was talking about. And what is again very important is prediction. Obviously, BP, correctly measured BP with the patient sitting comfortably. The cuff should be appropriate, particularly in obese and very thin patient. And look at Korot-Koff, 1 for SBP and 5 for diastolic blood pressure. But if you find that DBP is persistently less than 40, use the muffling of the 4th sound and make a note of it. And obviously, though we know that the mercury sphygmomanometer is a gold standard, but we know also that calibrated aneroid can be used. The automated machines can be used, particularly for home BP monitoring, but they have to be calibrated from time and again. And this is much more easier to use. And the patient should be comfortable. Simplest thing is empty bladder and should have not had chewing, tubing, tobacco or nicotine just half an hour before. There should be no anxiety. Tight clothing should not be there. Quiet environment. And if you find that the BP is on the higher side, let the patient wait, relax a little, and then after about 15 to 20 minutes, you can take the BP again. And in the OPD, we generally look at 3 readings 10 minutes apart if the BP is high. But if the first 2 readings are less than 140 and diastolic is less than 90, then you can omit the 3rd reading. But remember, when there's a BP of 135, 85, be alert. Counsel this patient, call her back. If it is possible to do a BP monitoring at home or with the family physician, let them do that, but let them be counseled that if the BP is persistently 140 or 90, she needs to start off with the treatment, and therefore she should come more frequently to the OPD. During prenatal visits, apart from looking at the edema, also ask about symptoms like epigastric pain, headaches, visual disturbances. And if you find that these are out of proportion, make sure that you check the BP correctly. Now to talk about the other markers, we know that there is an increased resistance to blood flow in uterine arteries at the first trimester in those patients who probably would be associated with development of preeclampsia. And we have proven this with the help of the histopathology done later. But earlier times when we used to talk so much about diastolic notch, we're no longer including that, but a color flow mapping with a pulse wave Doppler, the mean PI is calculated. And if the PI is more than 95th centile, then the patient is labeled as a high risk. So in the first trimester screening, when you're doing the nuchal scan and dual marker, if you're looking at the Pape-Mom, if it is less than 0.5, this is predictive of a placental dysfunction leading to FGR. But you're looking at umbilical Doppler. This is one of the best tests for predicting the at-risk fetus. So when you're combining maternal factors and uterine artery PI rates, probably your detection rates of preeclampsia may increase from 36 to 59%. Of course, there's going to be a false positive rate of 5. But anytime you feel that the PI is more than 2 standard deviations above the mean, then it is taken as a screen positive, and this patient is again marked at risk, regular fetal monitoring, and start off at low dose aspirin. And this was probably the basis of the Aspirate trial, which I'm going to discuss a little later. Just a few terms before we go on to the Aspirate trial. Pape, we know, is a large glycosylated protein which is developed by the developing trophoblastic cells. And if you have a low level, it means that there will be a higher incidence of preeclampsia and FGR. But can you look at that alone? There will be false positive rates. But if you combine the Pape-Mom and the second trimester S-split by the placental growth factor ratio, probably you could predict the late onset preeclampsia with a detection rate of almost 87% with a false positive rate of 5. What about the placental growth factor? This is a vascular endothelial factor involved in trophoblastic invasion. And at 11 to 13 weeks, there is a decrease in pregnancy where there is aneuploidies or where there is impaired placentation. And in the second and the third, the fall could be because of patients who are going to develop preeclampsia or FGR. So again, they have detection rates of 55% and 33% with a 10% false positive rate. So now when you're looking at this particular slide, you can combine the maternal factors with the mean arterial pressure, with all the various biochemical markers. But what is found is when you're combining maternal factors, MAP, uterine artery PI, and placental growth factor, along with Pape, probably you get a much more better detection rate of preeclampsia at less than 37 weeks, almost 81%. And more than 37 weeks, you get a detection rate of almost 43%, which is again much more better than the previously detected rates. So the Fetal Medicine Foundation has allowed estimation of individual patient-specific risks of preeclampsia requiring delivery before a specific gestational age. What they do is they combine the a priori risk from the maternal factors, and this is combined with the results of combination of the biophysical and the biochemical markers. And this was a prospective multicentric study. It sort of demonstrated the feasibility of incorporating first trimester screening, incorporate a preeclampsia detection also into the routine clinical practice. And when you're combining all these factors, they're finding that there is a 77% detection rate for preeclampsia before 37 weeks, which is fairly good, and 43% for preeclampsia more than 37 weeks. There is a false positive rate over there. But what is important there is, though they have screened a large number of population, they have seen that there are patients of preterm preeclampsia and the term preeclampsia, which is a larger number. They found that if you are giving aspirin compared with placebo, this has resulted in a 62% reduction in the incidence of preterm preeclampsia. But as far as the term preeclampsia was concerned, there was not much of a significant effect. And of course, this was the whole study design. And on the basis of this, they said that look at all the maternal risk factors, collect the blood and check the mean arterial pressure, and do all the entire screening and give the fetal medical, there's a fetal medical foundation calculator, put all those values in that and give the patient a risk. And on the basis of that, start off with low dose aspirin, but they are recommending 150 milligrams. Now, just to summarize, NICE guidelines recommend identification of high risk group on the basis of 10 factors. They look at maternal characteristics, medical and obstetric histories, but this screening is a poor performance, and they have detected only 39% of the preterm preeclampsias with a false positive rate of 10. ECOG recommends use of aspirin in those women who've had a history of preeclampsia in more than one pregnancy or a history of preterm preeclampsia. Now, this is very, very stringent and takes only 0.3% of all the pregnancies, which means you're going to miss out a lot. Whereas ASPRE trial says they're detecting a lot more, and they are recommending 150 milligrams, and they are claiming the reduction of preterm preeclampsia by more than 60%. So FMF approach combines the a priori risk with the maternal, biophysical and biochemical factors. But when you're looking at the Indian subcontinent, where access to first trimester screening is not always feasible, or even if it's feasible, that expertise is not always available, then the gestosis course remains a very promising tool, as it can be done by anybody. You can teach the interns, even the nurses can be trained. The nurses have been working in maternity for a long time. And then once you know the score, start the use of low dose aspirin, though we recommend 75 milligrams, because currently even the FMF Foundation says that they have used a value of 150, but the RCT between which is better, 150 or 75 is better, is still not done. With 150, the incidence of abruptions are known to be higher. So we are still saying use 75 milligrams at least. Now, going on to the S-split, we all know that it is an anti-angiogenic protein which antagonizes the growth factors. So the levels of S-split increase prior to onset of clinical disease, and they appear to correlate with the disease severity. So when you're doing the ratio of raised S-split to the decreased placental growth factor, if that ratio is elevated, you know that the clinical onset of preeclampsia is going to be there. And this is the basis of the prognosis trial. So this is a valuable aid in diagnosis and can discriminate between the different types of pregnancy-related hypertensive disorders. So if you have a value of 38 or lower, it can predict absence of adverse maternal and fetal outcomes within 1 week. Anything which is going above 50, 75, 95, all those are high predictors for preeclampsia. Of course, this can be used, and this is being used in certain centers, but I'd like to mention that if you're trying to adopt this particular test in clinical practice, it has one advantage: to reduce the frequency of adverse pregnancy outcomes, and it also gives you time to transfer the patient to a tertiary care center, and unnecessary hospitalizations are also avoided. And for this, they have done the PARROT trial at Ireland, and they found that in the patients who are coming to the triage, they're doing the hypertension, they're checking the blood pressure, they're doing the dipstick proteinuria. But if you're doing the placental growth factor test, women who've had a positive test result, it halved the time to diagnose preeclampsia and lowered significantly the chances of serious complications of women. And now they're recommending to do it twice in the pregnancy. Of course, the PARROT 2 trials are also going on. We're waiting for the results. And the basis of all these biochemical factors, test has been developed by some of the companies, and you currently now have test kits which look at the ratio of S-split and placental growth factor, and you can piggyback this to the first trimester scan, nuchal scan, and dual marker, and it has a good sensitivity of 82% and specificity of 95%. The cost currently in Mumbai is around 2,000 rupees. So this is the EVICO screening methods, and EVICO has got also the advanced screen reports, and this is what it looks like. So these are what the values come out. And what we have to also say is, very importantly, if you want to use these tests, by all means use it, but it may not be accessible to the patients who are poor or in the public hospitals. So you still have the full PIRES and the mini PIRES model. This is basically, again, looking at various tick mark signs of various risk factors along with the medical problems. The ability to recognize women at highest risk of complications earlier could aid in preventing adverse outcomes. And when you're doing the full PIRES model, this will aid in identify women who will probably develop an early onset and who are at the highest risk of adverse outcomes. So they're looking at history plus, the high BP is noted. They're looking at parity, gestational age, chest pain, and along with that, they're also adding pulse oximetry. They're looking at the lab tests, the creatinine and full transaminase concentrations. This is in the full PIRES. In the mini PIRES, you're looking more at the physical science along with the pulse oximetry. But what I'd like to say over here is a very promising test now has come on, the Congo red test, and two countries, Bangladesh and Mexico, have actually done this prospective diagnostic case control study in 409 women. Here it is found that misfolded proteins in the urine of women who have got preeclampsia, then in these cases, it will be turned as red. It is known as a urine congophilia, because this is basically an azo dye which exhibits affinity towards the filamentous protein aggregates and is used as a gold standard for identifying the amyloid fibrils. So if you find that this is positive, then probably this patient will develop preeclampsia. And with this prospective diagnostic study, which was done in Bangladesh and Mexico, they found that this particular test, the GV00 type is what they call, it is a beta prototype of a point of care test for detection of urine congophilia and seems to be a promising tool for the rapid identification of preeclampsia. So we're waiting for little larger studies for us to practice. Just 3-4 slides more and I'm through. There is what we know as cell-free fetal hemoglobin. High level is found in the placentas of patients who are diagnosed with preeclampsia. Now, HbF has got bad properties of inflammatory and oxidative tissue damage. Now, A1M is a protein, which is actually a protector protein. It is a reductase and binder of heme groups and organic radicals. So how does it do it? It damages against the cell-free fetal hemoglobin. So it reduces the heme and oxidative stress. And Bester and Rosenloff have found that if you give an IV supplementation of recombinant A1M protein, it may compensate for the increased HbF and the oxidative levels and may relieve the symptomatic clinical expressions of preeclampsia. And then, of course, they've talked of apheresis. There's a procedure where they are therapeutic apheresis with the plasma-specific dextran sulfate column, and this removes the circulating S-split, and probably these S-split levels get reduced, and there's also a reduction in the protein creatinine ratio, and that's how it helps. So again, we're waiting for the proper bigger trials to come out for us to say whether this is good or bad. And the promising test, which I feel is a human umbilical cord cell. These are basically having excellent anti-inflammatory, immunoregulatory, and repair effects in animal models. So what they're saying is that today bone marrow is an invasive procedure to get the MSCs. So the human umbilical cord blood cells is rich in MSCs, and this contains all the features similar to the MSCs found in bone marrow. So regenerative effects of placenta or umbilical cord derived MSCs could potentially treat the endotoxins induced by the hypertension that occurs in preeclamptic patients. So last slide. Apart from all these things, most important is we have to increase awareness in our healthcare workers, which includes our gynecologists, our family physicians, our resident doctors, and patients have to also understand the seriousness of HDP. Most women with a history of HDP were not satisfied with the information that they received. So which means that they have to be told better, they need knowledge. Everybody doesn't have access to Google. The people who are not as educated, we must be able to provide better communication. Focused information on HDP and postpartum period is also required, and education of caregivers is strongly indicated. So once again, I know we have wonderful people doing ultrasound. We have lots of centers doing Dopplers and biochemical markers, but public hospitals still lack the trained manpower, machines and biochemical markers, and therefore when GOI, Government of India, says 2 scans are mandatory, how can you have every patient with a nuchal scan and dual marker? They're saying at least do the anomaly scan. So in these situations, Gestos is easy to use. Congo red test seems promising, but we hope it can be practiced soon. So the Gestosis early antenatal registration, use the Gestosis score and positive treat with low dose aspirin and calcium. and use the gist dose score at every visit. So if it's upgraded, you know that you have to start off with low dose aspirin. Monitor women and the fetal growth. Use max self, timely transfer of the patient. Monitor BP in the postpartum period, lifestyle changes, and contraception. Thank you very much.
Thank you so much, ma'am, for your take-home messages and how to screen in India, basically because of the poor resources in our country. So I think gestosis score is will be a boon to our patients for screening for early onset preeclampsia as far as the maternal morbidity and mortality is concerned, because early onset preeclampsia is more dangerous than a late onset preeclampsia, and we can by screening we can prevent this morbidity and mortality also. And you rightly said that some of the trials are going on, and let us hope for the best, that we can have some easy screening test that can become more sensitive to all our patients. Thank you so much. One more thing I would like to say, that one Canadian trial is just published recently, that they have screened for patients for only the placental growth factor test. So if it is more than 100, then these are the patients who are more likely to go in early onset preeclampsia. And in that patients, they can start low dose aspirin as well as monitor closely, and they can start antihypertensive treatment earlier to prevent this placental dysfunction.
Thank you. And that's actually the basis of the parrot trial.
Yeah.
Carried on in Ireland. Yeah.
Thank you, Chairperson. Thank you, ma'am, for enlightening us on this vast subject in a very crisp take-home messages. And moving forward to the next session, I would like to invite Dr. Kirtan Vyas to take it from here. And just reminding my residency days, we used to do ophthalmic artery velocimetry for the prediction of PIH for my thesis topic. So I'm very eager to hear what the next session has to share with us. Over to you, Kirtan.
Yes. Thank you, Dr. Archana, madam. And with this, we move forward to our second session. For that, I would like to invite our esteemed chairpersons, Dr. Ajay Mane, sir, and Dr. Vandana Bansal, madam. Dr. Vandana Bansal, madam, is an obstetrician with super specialization in fetal medicine and interventions. And she has to her credit many publications, many book chapters as an author. And she has been a national coordinator of Imaging Science Committee, as well as the chairperson of Fetal Medicine Committee of AMOGS, and so many different awards and accolades to her credit. So we welcome you, Dr. Vandana, madam. We also have our other chairperson, Dr. Ajay Mane, sir. He is the vice president elect for FOXY and second joint secretary of AMOGS. And he has been a member of.
We can skip that. We can.
Yes, sir. Yes, sir. So many awards, sir. We welcome you, sir.
Thank you. Shall I introduce him? Yeah. Okay.
Yes, sir.
So I'm very much happy to be part of this very prestigious event. All my teachers are there. So Suchitra ma'am, Girja ma'am, my brother Gorak bhai, Sneha madam, and my very near and dear brother and friend Kuldeep sir. So I'm very happy to introduce him.
So your voice is not audible properly.
Hello, is it okay now?
Yeah, better.
Yeah, now.
Okay.
Better.
Yeah. Dr. Kuldeep Singh is a great ultrasound specialist. Whatever you label him, he fits in that definition. So he's a very eminent teacher. So I have seen him at least 500 to 600 times. He practices ultrasound in New Delhi and known for his skills in ultrasound. He has more than 600 talks in national so it is a old akada basically. It must be more than 1,000 and 2,000. He has been invited to share his academic experience in Japan, France, Spain, Italy, Belgrade, Dubai, Seoul, Dhaka, Kathmandu, Philadelphia, and Singapore. And he has received 4 awards and 3 gold medals in the field of ultrasound. He has authored 16 books on ultrasound in obstetrics and gynecology and infertility. His book have been translated into Spanish, Chinese, and Portuguese. I think with such a vast biodata, he must be the only one sonologist from India, I think. He was awarded the Imaging Science Award in the AIC Delhi, and he is successful running Sono School. For throughout the year, he is teaching all the students and doctors and all experts and making them all more experts, which organize various training programs in India. So I welcome Kuldeep sir. I have heard him, and his motto is prevention is always better than cure. So predicting HDP through the sonography, as Suchitra madam said, at least 2 sonography is needed. So the work is done by Kuldeep sir. So I welcome you and request you to kindly proceed with your lecture.
Thank you, sir. Thank you so much. Thank you, Dr. Sneha. Thank you, Dr. Vanna. Thank you, teachers. Thank you, Suchitra ma'am, Dr. Girja, Dr. Alpesh, Dr. Pai. We're going to be starting. There's going to be a bit of an overlap between the FGR and the P, but it's basically what we're looking at and doing on Doppler that's most important. I'll start sharing my screen. I hope the screen is visible and the slides are moving.
Yes, sir.
Perfect. So we're going to talk on ultrasound and hypertensive disorders of pregnancy. I'll just minimize the photograph so that then the many of you members of Sono School, so it's always a pleasure to be again meeting everyone. As rightly said by ma'am in the same slide, I'm going to be talking about the INSEO guidelines as well. Hypertensive disease of pregnancy affects up to 10%, and the pooled global incidence of preeclampsia around 3%. Major contributor for maternal and perinatal morbidity and mortality. And what's needed is a timely and effective care, which is going to improve the outcomes. So we need effective prediction and prevention strategies, major objective of prenatal care. The use of ultrasound as a tool for screening prediction is based on the fact, which ma'am has already explained, but I'm just going to take a few slides because then I can take it from there, that it's basically because of a defective placentation resulting in incomplete transformation of the spiral arteries. So we have the spiral artery invasion, we have the radial artery invasion, but we bothered more about in the NT scan to look in for that so that we can start the treatment before 16 weeks onwards. The placental villus and vascular histopathological lesions are 4 to 7 times more common in P rather than in non-P pregnancies, and it's associated with an increased resistance to uterine artery blood flow. A few statistics, if you're looking at an increased PI in both first and second trimesters, there's plenty of confusion, there's plenty of dilemma still, whether should it be used in the third trimester, but definitely in your NT scan and in your anomaly scan, it has to be. And if you're looking at a PI in the first and it's still seen in the second as well trimester, it shows you a high risk for adverse pregnancy outcomes. A normal pulsatility index, we have these 3 indices on ultrasound, the SD ratio, the resistive index, and the pulsatility index. And everywhere we're using the PI for the uterine arteries. 95% chance of normal measurements in the second trimester, and this group is associated with low incidence of adverse outcomes. So when you're looking at increased impedance to flow in the uterine arteries, for routine antenatal care, it's identifying about 50% of those that would develop preeclampsia. Abnormal Doppler better in predicting severe rather than mild preeclampsia, and the sensitivity for severe is around 75%. To get it correct, the ones who have a severe preeclampsia, in 75% was noted that they had a problem in the uterine arteries. The same thing goes for FGR, where we're looking at better in predicting severe rather than mild FGR. So if we're looking at a normal uterine artery, this is the risk for FGR, for preeclampsia, for perinatal death. Mind you, even if it's normal, it does not mean that there's no risk for these. There is, but it's quite less. But if it's abnormal, the risk increases of FGR by 5 times, 10 times of preeclampsia and perinatal death almost 3 times. Now, once we have an established preeclampsia, what are we going to be doing about it? The deteriorating fetal status is one of the indications for delivery in PE. So close fetal surveillance is needed until delivery. And the 3 main components are, you need to be doing your 2D. It's not that straight away Doppler and that is it. No, you need to be carefully visualizing your B mode ultrasound. What all has to be seen in that, I'll let you know just now. The Dopplers, what all vessels, I'm going to be letting you know, and we need to be doing the fetal heart rate monitoring. Fetal deterioration and indication for delivery, the fetal status has to be assessed regularly. The sonographic follow-up in pregnancies affected by PI, we need to be assessing the fetal growth on 2D. We need to be doing a biophysical profile consisting of all the 5 factors, the Leica, the NST, movements, breathing, and tone. And we need to be doing our fetal Doppler studies. When we have so many studies and so many research papers, it means we still haven't been able to come on to randomized control trials. So we still need to know how often and when to deliver and how soon to be seeing them again. So when you're doing your fetal biometry, you're assessing the amniotic fluid volume, you're assessing the uterine arteries, umbilical arteries, and the middle cerebral artery. You need to be assessing the cerebroplacental ratio. I haven't put in the aortic estimate specifically because not many of us are doing it. So that's why the routine ones I've added that. You need to be visualizing the placenta to exclude abruption. And if a patient is presenting with these features, headache, abdominal pain, bleeding or reduced fetal movements, and we know the blood pressure is quite high, we need to be careful. The same tests have to be considered for women, not only for these symptoms, but for PE, suspected PE, or with a HELP syndrome. The fetal biometry to be assessed so that we can know, is the baby SGA, FGR, and how soon are things going to be going bad. In terms of the biometry, it's supposed to be measuring in the cranium, the BPD, and the head circumference. The femur length has to be assessed and the abdominal circumference. Various formulas, and now we have Indian charts which you can feed in your machine. You should be able to calculate the estimated fetal weight. That's the section for the cranium, the transthalamic view, that's the thalamus. The cavum septum pellucidum. Outer to inner is the BPD. Along with this, you're going to be looking at the OFD from outer to outer. Enveloping the complete cranium is going to be the head circumference. Be careful that you're not looking at the kidney, that's the suprarenal. Supposed to be looking at the stomach bubble, this J shape of the portal vein, and you're supposed to be measuring the abdominal circumference. Don't unnecessarily put pressure that it gets deformed. And from shadow to shadow, you're supposed to be measuring the femoral length. The moment you have, make sure that all these, you're having the same ID, so that then you can always and always chart them up, so that you know whether is it was supposed to be here and is it going below the 5th percentile? Was it on the 90th percentile and now it's coming down, or it's there throughout like this, which is a constitutionally small baby. When you need to be looking at the placenta, be careful of the signs. If you're looking at a thick placenta with diffuse echogenicity, with the blood pressure going high, you need to be looking in for, because that could be because of edema. If you're looking at thin placenta, could be because of reduced vascularization. You can be looking at cystic areas because of infarctions and hematomas. Be careful of looking in for partial or total abruption, and be watchful that when you're looking at the placental myometrium interface, it could be almost isoechoic. So don't make that mistake that there is no problem. Just be watchful, just be patient and see that, because the sensitivity of ultrasound in diagnosing placental abruption is poor. We always know when we are looking at FGR, when we're looking at these troubles, there's going to be oligohydramnios. You need to be measuring the amniotic fluid index properly. You need to be keeping your probe perpendicular to the obstetric table, parallel to the midline, and you're supposed to be adding up all four quadrants, excluding the limbs and the umbilical cord, or you can take a deepest vertical pocket. When you're looking at a deepest vertical pocket, maximal depth, free of umbilical cord and fetal parts. For the deepest vertical pocket, less than 2 oligohydramnios, 2 to 8 is normal, more than 8 is when you're looking in for polyhydramnios. You need to be going like this. Don't have unnecessary in oblique or going like this. Do not include the limbs and the umbilical cord. Nowadays, we have fancy machines which can just add it up. Otherwise, you can just use a calculator. Now we come on to the most important portion, and that's the Doppler. The 4 Doppler territories which we need to be looking at: umbilical artery, middle cerebral artery, ductus venosus, and the uterine arteries. Under physiological conditions, 60 to 70% of umbilical venous blood in the human fetus is distributed to the liver. Remainder by the ductus venosus goes to the heart. When you're looking at hypoxemia, this proportion is modulated so that we send in more purified blood to the heart and to the brain. So as an early adaptation, we're going to be looking at increased blood flow in the ductus venosus to protect the brain. There's going to be a brain sparing because of central redistribution. And there's going to be reduced flow to the peripheral and placental circulations. Severe fetal redistribution would normally be followed within 2 weeks by development of reduced biophysical profile. Abnormal venous Dopplers and suboptimal CTG. A growth-restricted fetus would usually develop an abnormal umbilical artery before developing fetal arterial redistribution. This is something which we've been doing for the past few years, and it's extremely important. The cerebro-placental ratio. It's basically the MCA PI divided by the umbilical artery PI. Before any of them goes, in the sense this value is going down or this value is going up, if you find a change in the CPR, just be watchful. A CPR is abnormal even when the individual values are normal. If you're looking at less than 1, it's an earlier sign of redistribution and cerebral hypoxia. Venous Dopplers helpful for less than 30 weeks. What you need to be doing is you need to get the steroids. You need to be knowing how I'm going to be increasing day by day. So the essential goal at that time is to prolong the pregnancy by 1 or 2 days to allow therapy for lung maturation. So venous Doppler is additional non-invasive information on the functional capacity of the fetal heart. Apologies, I'll just have a sip of water. It's just too many webinars and too many talks. This is basically to help determine the optimum timing of the delivery. So when you're looking at absent or reversed and diastolic flow, what the latest things are saying is, if you're looking at 32 weeks and you're looking at reversal, deliver. If you're looking at 34 weeks, you're looking at absent, deliver. But before that, if problems are happening and you need to prolong, do the venous Dopplers. If you're looking at an SGA fetus, the weight is less than the 10th percentile, meaning but the Doppler values are all normal, you need to be watching them every fortnight. And labor induction to be recommended at 40 weeks, the Gratikos classification. You're looking at normal uterine artery. There is no notching over there. The diastolic flow is plenty. That's the uterine artery. That's the iliac vessel. Looking at a free loop of umbilical cord. The red and the blue denoting flow towards the transducer or away from the transducer. Normal flow seen over there. You could be looking at the PI to calculate the CPR. Then I normally follow the SD ratio for every week of gestation. Normal flow. We'll be gradually showing you abnormal flow as well. We're looking at the middle cerebral artery, the circle of Willis seen over there. And you're looking at normal flow. The moment the diastolic flow starts to increase, meaning we're looking at brain sparing, because the more the diastolic flow, we know the more is reaching the brain as such. All these values, the SD ratio, PI, and RI, they denote the resistance. So if these values are high, meaning the resistance is high, meaning the blood flow is less. So if I need to be sending in more blood to the brain, the resistance has to go down, so the diastolic flow increases. Ductus venosus. That's the liver over there. We're looking at the stomach, umbilical part of the portal vein, and the moment it divides, it becomes narrow. That is why you can see a little aliasing and turbulence. That's the best way to insonate it. And you're looking at an M sort of a pattern. Ventricular systole, ventricular diastole, atrial systole. This is what we are concerned with. This is below the baseline. You can always make it reverse so that it can come up then. The M sort of a pattern seen in ductus venosus. Now we're looking at a mild insufficiency. When you're finding problems in the uterine artery, umbilical artery, or the middle cerebral artery, or the CPR is abnormal. Weekly monitoring, labor induction beyond 37 weeks. You're looking at uterine arteries. You're looking at an impedance which is high. A mean uterine artery PI done transabdominally should be less than 2.35, irrespective of the notches. If you're doing a transvaginal, it should be less than 3.1. You're seeing in the second trimester. In the second trimester, the mean uterine artery PI should be less than 1.5. In the third trimester, it should be less than 1.17. You're looking at decreased flow in the umbilical artery. Decreased flow in the umbilical artery. So we know the resistance in the umbilical artery is increasing. You're looking at a PI of 2.11, an SD ratio of 6.87. Gradually looking at an increase in the diastolic flow in the circle of Willis at the middle cerebral artery. We're looking at a PI of less than 1. That's 0.75. We're looking at even more insufficiency, where we're looking at an absent umbilical artery flow or a reverse in the aortic isthmus. You need to monitor them twice a week. Again, it does not matter. We're just looking at the Doppler findings. We need to be making sure how much are the clinical parameters and how is it being followed. Delivery to be recommended after 34 weeks. Absent and diastolic flow. Absent and diastolic flow, you can see how wide the middle cerebral artery is, and you're finding an increase in the diastolic flow. You're looking at deterioration now. Reverse and diastolic flow. Or you're looking at the ductus venosus PI, which is increasing, meaning the atrial systole flow or the lowermost portion is reducing. You need to monitor them every 24 to 48 hours. And delivery, if you're looking at such a situation, after 30 weeks. Reversal of flow. Reversal of flow. And you're looking at reduced flow in the ductus venosus. That's the atrial systole flow, and that's reducing. We know we are heading for trouble. When we have high suspicion of fetal acidosis, where we're looking at spontaneous deceleration or a pulsatile ductus venosus, monitoring to be done 12 to 24 hours. After 26 weeks, we need to be delivering, again, depending on how the center at which you're delivering is equipped for. You're looking at deceleration. You need to be watchful. So when we're looking at an elevated umbilical artery, it has an overall perinatal mortality rate of 5.6. Doubles when you're looking at end diastolic flow is absent. But it increases if we start from here 6 times if you find the venous Doppler indices are becoming abnormal. So reverse flow in the umbilical artery with pathological waveform in the venous system, best predictors of distress, and termination has to be done as soon as possible. The frequency is always dictated by the severity, by the gestational age. If you need to do a biometry, please do not do it every 48 hours. It's immaterial, it's useless as such. You need to be doing it at least 10 days, otherwise ideal is more than 2 weeks. Depending on, you need to be looking at the amniotic fluid index, and you need to be using your Dopplers wisely. The gestational age at decompensation is the primary determinant. The neonatal care available dictates the gestational age. If you're not going to be able to sustain, there's no point, they have to be transferred on. Less than 32 weeks, every day gained is useful. Every week gained, the outcome improves by 40%. The venous Dopplers are going to help us in delaying the delivery. What we need to be looking at, just a live fetus? No, we're looking in for intact survivability. So the risk of intrauterine compromise has to be weighed against the potential risk of iatrogenic premature delivery. Last 3-4 slides. Briefly, absent or a reversed end diastolic velocity in the umbilical artery, strongly associated with perinatal morbidity and mortality. If you're looking at reduced MCAPI, it's a sign of brain vasodilation associated with emergency cesarean delivery, because if you're looking at non-reassuring fetal heart rate. If you're looking at a CPR less than the 10th percentile, again a sign of hemodynamic redistribution. The reversed A wave in the ductus venosus, strong manifestation of fetal cardiac deterioration, high risk of perinatal mortality, severe neonatal morbidity. Be watchful for that. So before you land up here, you need to be watchful, deliver them early. So if you're looking at an abnormal umbilical artery and is achieved when the delivery is postponed until the A wave in the ductus venosus becomes reversed. So be watchful before that happens, just tend to deliver them a little early, even if you need to be doing a few more scans, because it's always advisable rather than the baby being in the NICU and we're looking at trouble. The primary goal of antenatal evaluation is to identify fetuses at risk for intrauterine injury and death, so that intervention and timely delivery can prevent progression to stillbirth. So last message, decision to deliver is an optimal balance between minimizing fetal injury or death versus risk of iatrogenic prematurity. You need to be doing your Dopplers, otherwise, even if somebody else is doing it, you need to be looking at the pictures and the values so that then you're doing a good job. Thank you so much.
Thank you, Dr. Kuldeep Singh, for such an excellent lecture. I think sir has covered everything that we need to monitor on ultrasound in preeclampsia, starting from the preeclampsia prediction, which is very important, especially the use of uterine artery Doppler along with PLGF and PAPE. And also once the preeclampsia is developed, then the monitoring that sir has spoken about is to monitor the growth, the biometry, look at the Lie curve, and mainly the Doppler. So what sir is trying to say is that prior to 34 weeks, umbilical artery and ductus decides, because every day that we count additional, we are helping the baby to survive with intact survival. And probably after 34 weeks, it's the MCA and the CPR which decides on the timing. So ultrasound is extremely important for management as well as timing the time of delivery. So that is extremely important. And I think that will also be covered by Dr. Girija Wagh. Madam, can you comment on sir's lecture also?
Dr. Kuldeep, excellent talk as always. Wonderful. It's always a pleasure to hear to you. And I enjoyed each and every take the end. Which I wanted to ask you was, sometimes when we are doing the Dopplers during pregnancy, we find that the uterine artery PI will be there positive at around 12 weeks of gestation, and then at 16 weeks of gestation, either you have started her on low dose aspirin. Sometimes I also give them LRG9, and then the uterine artery PI may remain persistent, but many times it will also disappear. Now, is it something you mentioned that even one time, if you are seeing resistance during the antenatal course or any kind of an abnormality, you must be on guard with that patient, I understand. But then is it trying to tell us anything different? That was my question number one. Question number two is, I've started looking at every time that I do an anomaly or an anatomy scan, especially in the 19-20 weeks, I also look at the femur length. And sometimes if the femur length is less, I feel that maybe this is an invitation for some sort of a placental insufficiency in the future, which can be an opportunity now to correct her diets or maybe give her some, with that be on guard, let's take care of you kind of a situation. So, because I know there are very small studies, they do not have, but what has been your experience or what is your opinion about this? Because you're doing so many Dopplers. Do you want to comment on this?
Yeah. The first thing, ma'am, which you said about the uterine artery, the problem is, if we're going to be starting them on aspirin and whatever 75 or 150, and then we again see them at 20 weeks, and then we figure out that they become normal. Now the catch-22 situation is, should we stop or should we not? So that becomes a major hassle. The other thing is, if we have a uterine artery PI which was on the higher side, there is a notching over there, there is more on the 95th percentile. We're looking at the same thing again in the second trimester, and the values are almost there, or it's, let's say it's 1.6 or 1.7, then we need to be following them up a little more closely at 24, at 28. That's always the norm, because we know once the uteroplacental insufficiency is still persisting, we're going to be looking at a fetoplacental insufficiency. When is it going to start? Rather than calling them straight away at 32 weeks, it's better to do at 24 and 28 as well. Regarding the second question is, that if you're looking at a very early onset FGR where the abdominal perimeter is going down, that's the first step. If you find the femur length is also going down and you find that the parents are of a reasonable height, first has to be abdominal perimeter, second femur length. We know we are a step ahead in landing up into trouble, so we need to be even more careful. So that's the only thing. But if you're looking at the abdominal perimeter normal and the femur length reducing, then also one has to see in terms of centiles, where is it? Because the difference of a week or 2 weeks really does not matter too much in the anomaly scan.
So what is the role of ophthalmic artery Doppler for prediction?
I to be very honest, I don't do it. Yeah, I don't do it.
It's still
it's more, there are many people who are doing it, but it's more in the hospitals. To be very honest, I have not been doing it. Dr. Archana mentioned it, and I said, might be nobody's going to ask me that question.
So it was hesitation. So I just going through sonography. It is almost, I'd say, almost 20 years back I'm talking about, but
I think so.
Visiting the ophthalmologist because that time color Dopplers were not so rampantly available.
And there's so many now more new biochemical factors which Dr. Sutra ma'am has said that now the reliance or the thing on ophthalmic artery is a little less. Now they're coming up with, in fact, The maternal cranium also, that they're saying that we're going to be doing it with our small parts probe, giving you a wider view so that then you can look in at the vessels, the cerebral arteries of the mother as well to figure out how bad are we going. So let's see how it happens in a few years.
I think we had a very fruitful session. Girija ma'am, you want to say something?
No.
So I think we'll proceed to the next session. Thank you, sir, for enlightening us, because I feel the Dopplers are always a mystery. Demystifying any type of Doppler study is always very welcoming to hear, and it's a learning experience, sir. Thank you for sharing your knowledge with us.
Thank you, Jane.
And now welcoming our next, I would say, Beauty with Brains, Dr. Girija Wagh, madam, is over here with us. And to chair the session, I would like to invite Dr. Naren Gajjar, sir, who is President Navsari Society and a very down-to-earth but very knowledgeable person. And let me tell you, he's such a humble person. He never refused anytime you call him for the help. And along with him, I would like to invite Dr. Jitendra Patel, who's president of Nadia Anand Society, to chair the sessions of this session. And I cannot see Jitendra sir, so Narendra, just would you do the honors to introduce madam?
Yes, sir.
So much, sir.
Okay. So, may I take over? Hello.
Yes, absolutely.
Yes, please, sir. Please,
So
sir.
it's a pleasure for me to introduce Dr. Girija Wagh for a very important topic, antihypertensive, when and why. See, routinely we are using these drugs, but sometimes it happens that which drug to be used in which dose, and when it is not controlled, which drug to be added, it's a dilemma for us. And so I request Dr. Girija Wagh to highlight these points. She's a professor and head of the department, Bharati Vidyapit Medical College, Hospital, Pune.
Okay,
Senior
sir,
Hello.
thank you so much. I think I'll post it in the chat box.
Okay, madam.
We'll take
So,
the time.
okay. So kindly proceed with the talk.
Thank you so much, sir. So at the outset, I would like to congratulate Sneha for bringing up two important societies together, the Gujarat Society and the Maharashtra Society, under the aegis of the Medical Disorders Committee. Congratulations, Sneha. You always come up with wonderful ideas, and I can see how hard you are working to connect to people through education and academics and social work. And I'm sure that you will crack the election with great numbers this time. And I request all of you to support Sneha, because we have to continue to nurture the academics in our wonderful organization that is Foxy. I was a little scared when Madam Vandana said that I'm going to speak about management of HDP. No, I'm only going to focus my talk to the antihypertensives, which, when and how, and that is the task I believe that Sneha has given to me. So thank you for that very kind introduction, Professor Gajjar, and it's really important for me, and I feel privileged that you have introduced me. Now, we all know that hypertension, either pregnancy related or chronic, is a common complication of pregnancy, which is really rising in incidence. And especially we must be aware that severe blood pressure of 160/110 or more can cause stroke and death and even myocardial infarction, and prompt recognition and treatment is important. The moment a woman is diagnosed with hypertension, the major issues are establishing a diagnosis as to what kind it is, determining the threshold for initiating the treatment and the target blood pressure, avoiding drugs with potential fetal effects as well as maternal effects, and then, of course, the timing of delivery, which is important. Now, if you look at the conglomerate or the spectrum of the hypertensive disorders in pregnancy, they would be involving everything from a woman who is already a chronic hypertensive, or later on she develops gestational hypertension, late onset preeclampsia, that is proteinuric hypertension, and early onset preeclampsia form the main game changers, because they really contribute immensely to perinatal morbidity and mortality. And the new entity which has been understood now is the new onset postpartum or intrapartum hypertension can also be there. And therefore, one cannot ever replace the regular blood pressure monitoring of women in any given situation. I can see some young postgraduates here attending this conference. So I would like to say, never ever relegate that BP measurement out of your practice. It is extremely important because that is the single measurement which is going to guide you as to where and what you have to start with the treatment. So whenever you have blood pressure of more than 140/90 before pregnancy and before 20 weeks of gestation, typically seen in older obese or Black women, increased risk of preeclampsia, FGR, and heart issues can be there. And it is, if the chronic hypertension is higher, it's severe, there are higher chances of adverse outcomes. And usually most of our definitions differentiate based on when they occurred before 20 weeks, or whether they occurred after 20 weeks of gestation, or whether they remained or occurred after delivery. Now let's look at a case scenario of Mrs. CGS, who is 32 years of old age, and she had a first miscarriage at 6 weeks. Her body mass index is 36. Her blood pressure was 140/90 milliliters of mercury, and she has conceived with ovulation induction with clomiphene citrate, and she was also given HMG, plus she was given HCG for ovulation trigger. And she became pregnant, and she confirmed her pregnancy at 7 weeks of gestation, and her body mass index, as you can see here, is 36 kg per meter squared. She has history of PCOS and hypothyroidism with positive thyroid antibodies, hemoglobin of 10.5, HbA1c of 5.9, and you can now remember the Gestosis score, which Madam told, and you can see that there are various factors that are there in this patient. So she becomes a high-risk mother, and she has a risk of developing perinatal adverse outcomes and preeclampsia. And now what is very important in the context of our today's talk is she's been taking atenolol 25 milligrams OD for the past 2 years, and her urine routine examination is within normal limits. What I mean to say that is there is no proteinuria when we checked her. Now we have to understand that chronic hypertension is a very common occurrence, affects about 3% of pregnant women, and it is associated with preeclampsia developing about 13 to 40%, causing increase in C-section, PPH, gestational diabetes, triples the risk of perinatal mortality over general population, doubles the risk of placental abruption, and if baseline proteinuria, increase risk of preterm births and small for gestational age babies. And we all know now, today with women postponing their child rearing and bearing to 30s and 40s, with obesity confounding it, this is on the rise. Now, whenever you have a woman of chronic hypertension, you should not typically act like only a pure obstetrician. You must ask her what is the duration, the baseline investigations, systemic evaluations are necessary, and you must analyze comorbidities. Because there are various reasons why she must be having chronic hypertension. Most commonly, it can be an essential hypertension, but it can be secondary to renal, endocrinal, vascular problems. They can be drug-induced, and there can be miscellaneous issues. It's always a good practice to ask the woman about sleep apnea, and they'll tell you, yes, I snore, I have started snoring. That also adds to the risk assessment score. Now, normally, we know that many times women are started in a chronic hypertensive when they're not pregnant. ACE inhibitors are what are very commonly given to women for hypertension control. Now, especially these are agents that block the production of angiotensin, and angiotensin converting enzyme inhibitors is therefore what they are called as. And what are these medicines? The captopril, enalapril, and lisinopril. And these are associated with increased risk of fetal abnormalities. Their use is associated with fetal renal failure, growth restriction, oligohydramnios, pulmonary hypoplasia, and fetal death. And such fetal adverse effects appear to occur regardless at the gestational age at which these agents are administered. We typically remember or feel that it will affect her only during organogenesis. It's not so, even before. And if she's already taking, we all know that when she becomes pregnant, already they may have some teratogenic or amniotoxic effect. Another group of agents which are given are typically the ARBs, that is angiotensin receptor blockers. And however, we know that ARBs, the data is a little limited. They should be avoided as their mechanisms of action are like ACE inhibitors, and they appear to have similar fetal adverse effects. So why not atenolol? You remember our patient was on atenolol. A large retrospective study of atenolol used in pregnancy suggested it may be associated with FGR, especially when administered in early pregnancy and continued for a longer duration. She was taking it for 2 years. Evidence suggests that atenolol impairs fetal circulation and increases uterine artery resistance index and fetal aortic PI. Evidence also suggests that beta blockers may have long-term adverse effects on very low birth weight neonates, resulting in increased neonatal mortality. So whenever a pregnancy, if you're doing, if you're giving her fertility treatment, like you've decided to do ovulation induction, first remember to shift her antihypertensives. So care should be exercised when prescribing ACE inhibitors for women of childbearing age, as a significant proportion of pregnancies are unplanned. It should be avoided in women with chronic hypertension who are planning a pregnancy unless there is a compelling long-term indication, such as a history of diabetic nephropathy, and inform her doctor. She has to be told that if you are taking this the moment you become pregnant, please let me know because I need to change you to a suitable alternative. So women with hypertensive disorders, ACE, ARBs, and statins should be discontinued, and you should switch to alternatives when available with a better fetal safety profile, and that is methyldopa, labetalol, and calcium channel blocker like the nifedipine or Nicardia. So some more fuel to the fire of confusion is, it's been found that women with chronic hypertension, either treated or untreated, are at risk of congenital malformations in offsprings, particularly cardiac malformations compared with normotensive women. Although it is possible that hypertension increases the risk of congenital heart disease in offsprings and that antihypertensive drugs further increase this risk, it is also possible that hypertension itself acts as an embryotoxin, and therefore controlling the woman's blood group around conception is extremely vital to reduce such a possibility. Now let's look at the second case scenario of Mrs. A. She's 20 years of age and she is a primee at 34 weeks of gestation, and her date of admission is on 29/9/2022, 2 p.m. She came with severe preeclampsia with imminent eclampsia with a blood pressure of 190/120, albumin 2+. There are no other obstetric or medical risk factors identified. Her vitals, she's conscious, she's coherent, respiratory rate is 22 beats per minute, pulse rate is 98, and her SpO2 is 96%. So you can see this case scenario. What is this? This is definitely a very severe hypertension, and this looks like preeclampsia because there is proteinuria. 34 weeks means it's a late onset preeclamptic toxemia. HDU or obstetric ICU you must consider because she'll require a very, very close surveillance, and therefore you have to decide. Now this condition is hypertensive crisis, which includes hypertensive urgency and emergency, affects 10% of pregnancies, many with underlying chronic hypertension. Approximately 1 to 2% will undergo a hypertensive crisis at some point during their lives. So this emergency in pregnancy is persistent, lasting 15 minutes or more, acute onset severe hypertension, defined as SBP greater than 160 or diastolic blood pressure more than 110 mmHg in the setting of pre-eclampsia or eclampsia. Why do we have to act fast? This is a very typically asked question to the PGs. Why do you want to control her blood pressure? Because you want to protect her against cerebrovascular accidents, eclampsia, myocardial infarction, cardiac failure, and placental abruption. Especially beware of women with chronic hypertension or early onset preeclampsia. And this is because most of the times they will have some sort of a stroke or a myocardial infarction. There was this study which was observed by Martin et al. And published in 28 moms with preeclampsia who suffered stroke. And most of these strokes were hemorrhagic, associated with systolic blood pressure of more than 160 mmHg. So only 20% of these patients had diastolic blood pressure of more than 110, while more than 50% had chronic hypertension and blood pressure, systolic blood pressure of 160 or more. Why? What is so great in chronic hypertensive patients? They probably would have aneurysms in their typical intracellular circulation, which is called as the Charcot-Bouchard aneurysms. And they are present on typically the deep penetrating arteries, such as the basal ganglia, pituitary thalamus, adjacent deep white matter, pons, and deep cerebellum. And they are at risk of undergoing rupture in response to sudden rise in blood pressure. And therefore, we have to understand and be careful in these particular patients. And this is the paper I was referring to, published in 2004 by Martin et al., which spoke about the factor that severe systolic hypertension, rather than the severe diastolic hypertension, does not develop before stroke in most patients with severe preeclampsia and eclampsia. A paradigm shift is needed towards considering antihypertensive therapy for severely preeclamptic and eclamptic patients with SBP, which reaches or exceeds 155 or 160 mmHg. So the initial management of an emergency in the setting of preeclampsia or eclampsia generally includes rapid reduction of blood pressure using IV antihypertensive medications. And the goal is systolic blood pressure of 140 to 150 and the diastolic blood pressure of 90 to 100 units of mercury. Now, these are the typical antihypertensive medicines and the dosages in which they are given. If the BP is more than 160 by 110 and persistent for more than 15 minutes, first line is given if she is conscious. Our patient was conscious. So we could give her nifedipine, 10 milligrams per orally, never give it sublingually. You can also consider giving her an oral labetalol, 200 milligram, you can give it per orally. You must know your dosages correctly. For example, nifedipine 10 milligrams per orally, then 20, 20, and 20 can be repeated every 20 minutes by checking her blood pressure. Titrate it against the blood pressure. While you may consider, if she's unconscious, you may consider, or she's having altered sensorium, you may consider giving her an IV labetalol. Now, oral labetalol, you can give 200 milligrams per orally and may be repeated at 30 minutes. IV labetalol, 20 milligrams IV to begin with, then 40 milligrams, 80, and then you can consider giving 10 milligrams IV per hour, because that is how by that time she would have been stabilized, and check her blood pressure every 10 minutes. It's a good practice to put her on a multipara monitor so that you get the records. And hydralazine dosage I've written here, but it's not very easily available in our country. And internal medicine, anesthesiologist, critical care, your multidisciplinary team is always to be tapped, because you may need their help in such an hypertensive emergency. And the threshold blood pressure definitely should be less than 160 by 110, because at this point in time, you want to protect the mother against the consequences I described to you. So this is the typical chart which you can have in your own labor rooms and emergencies. And here I've spoken about labetalol and nifedipine. Now, additionally, in certain rare cases, you may consider using sodium nitroprusside. Start with 0.25 micrograms per kg per minute to a maximum dose of 5 microgram per kg per minute. But remember that if the baby delivers within 4 hours, there is a fear of fetal cyanide poisoning risk. And therefore, if there is still time for the baby's delivery, you may consider using it. Now, what are the other things that one has to remember? One has to remember certain important things. Nifedipine, never, ever to be given sublingually, because it will suddenly cause drop in blood pressure, which can be harmful and life-threatening to the mother as well as the baby. You must know the labetalol drug in and out, because it is contraindicated in active asthma, heart disease, CCF. Whenever there's bradycardia, you wouldn't give labetalol, then you would choose nifedipine. History of asthma should be asked. You should remember that if you're doing an NST on this baby or this mother, you may find a little neonatal bradycardia. You should also remember that sometimes beat to beat variability reduces in patients who are taking antihypertensive medicines. And then if the maternal pulse is less than 60, you'll have to hold the treatment of labetalol. So labetalol is an alpha-1 and a selective beta-2 blocker. And what is very importantly, the question that comes to our minds typically is, the action will last at least 8 hours following a single oral dose of 100 milligrams, more than 12 hours following single oral doses of 300 milligrams. And the maximum steady state blood pressure response upon oral twice a day dosing occurs within 24 to 72 hours. The adverse effects are a consequence you should be aware of: more than 10% bradycardia, dizziness, nausea, fatigue, and 1 to 10% may have bronchospasm, dyspnea, elevated BUN, elevated creatinine, and orthostatic hypotension. We already discussed the contraindications, and it has an advantage that it may enhance the fetal lung maturity and preserves the placental perfusion. While nifedipine, on the other hand, is another important go-to drug for us, which is a calcium channel blocker. 10 milligram BID may be increased to 120 milligrams per day, and slow release formulation is the best deal to use. Adverse effects will be edema, dizziness, flushing, headache, heartburn, muscle cramps, mood changes, nervousness, cough, dyspnea, and palpitations, and hypersensitivity. There are various regimens which you should be well aware of: the Parkland Hospital, the Sibai regimen, and the ACOG NHBPM regimen. What I described to you was the ACOG NHBPP regimen, and maximum dosages in any of these regimens do not exceed 220 milligrams. Now, it's always very, very prudent to use magnesium sulfate in such hypertensive crises as an anticonvulsant, neuroprotector, and a vasodilator. I particularly mentioned it here because many times there are reservations in using magnesium sulfate along with nifedipine. Do not worry, there are more than enough studies which have shown that they do not potentiate any of their actions and can be safely used. Magnesium sulfate not only prevents a convulsion, but it causes this particular action, helps through brain parenchymal vasodilatation, and especially this has been demonstrated. It causes protection of the endothelial cells, and cerebral perfusion is increased. And many studies are now showing that it would be also helpful in stabilizing the liver parenchymal cells, and there can be a treatment as used in HELLP. Other antihypertensives are verapamil, a CA antagonist, can be given intravenously. Nibotipine can be given orally or IV. Ketanserin is being studied in use for antenatal mothers, which is a selective serotonergic receptor blocker. And nitroprusside, or NTG, where we just learned that it may cause cyanide toxicity in the fetus. Experimental are calcitonin gene-related peptides, the CGRP, which is known as vasodilator, and endogenous digitalis-like factors, but these are still in experiment. Right now, at this point in time, with whatever information that we have to be absolutely understanding the fact that whenever you have a patient coming to you with hypertensive crisis, you have to put her on a checklist, see whether she has pulmonary edema, renal failure, myasthenia gravis. These are contraindications for magnesium sulfate. If not, this is the checklist which you can mark, give her magnesium sulfate, and then initiate the antihypertensive medications like labetalol or nifedipine. And you must do all the labs and start working on as a multidisciplinary team. If the woman has thrown a convulsion, then you have to give her a right position, the left lateral position, give her a lateral decubitus airway. And then here also you have to understand the first line would be magnesium sulfate, but also you would consider giving antihypertensives have to be given. If conscious, oral nifedipine or oral labetalol can be given, or if she's unconscious, you would start her on the labetalol drip. Now, from the NER Foxy ICOG data, when we studied the way in which 258 patients presented with eclampsia, it was found that 38.76% patient had blood pressure of more than 160, while 61.24% had blood pressure of less than 160. So naturally, when we look at the preferred antihypertensive, labetalol has the advantage that it can be given initially by mouth in severe hypertension and then shifted up to an IV. A review has suggested that hydralazine hydralazine oral tablets are available in some states, may be less preferable, although the evidence is not strong enough to preclude its use. There's also consensus that if the BP is below 160/100 millimeters, there is no immediate need for antihypertensive therapy, and I'm going to contest my statement shortly. An exception may be that there are markers of potentially more severe disease, such as proteinuria or disordered liver or hematological test. And in these alarming blood pressure issues, we must start antihypertensive treatment definitely, even for low blood pressure. So this debate continues about treating the moderate hypertension between 100 millimeters of mercury and 110 millimeters of mercury, diastolic especially. And the maternal treatment is associated with a reduction of severe hypertensive crisis and a reduction in the need for further antihypertensive therapy. That is the supporting point. And there appears to be a small reduction in the infant birth weight. So we shouldn't be really worried about the placental perfusion. With treatment, a prolongation of pregnancy of an average of 15 days is possible, as long as there is no other reason to deliver. And that is the USP of giving antihypertensives. So whenever you're talking of antihypertensives for temporizing mothers who are now warded of that crisis, where you're going to give them an expected management, or otherwise they don't have risk factors, but you have found them to be hypertensive, you may consider the oral antihypertensive therapy using labetalol, nifedipine, alpha-methyl-dopa, and angiotensin receptors and diuretics are best not used. Sometimes judiciously, you may have to consider. So the proper protocol, if you ask me, is this wonderful chart here, which tells you the first line of treatment being labetalol. Of course, the pulse rate of the woman will decide this. And you must understand contraindicated for the contraindications, and the low regimen would be 100 milligram 3 to 4 times a day. Medium, if BP is not controlled, 200 milligram 3 to 4 times a day. And if it is not controlled on the medium dosages, then you may consider a high dose regimen of 300 milligram 3 to 4 times a day. And that would be going up to 1200 milligrams per day. Now, nifedipine, we all know, is contraindicated with aortic stenosis, 10 milligram 2 to 3 times per day, 30 milligram once per day slow release formulation. Medium dose would be 20 to 30 milligrams 2 times or 3 times per day. And a high dose would be 30 milligrams each morning and 60 milligrams each evening, reaching up to 120 milligrams per day. And methyl dopa, unfortunately, is not very easily available. I don't know what is in the state of Gujarat, but in Maharashtra, it is not there. 250 milligram 3 to 4 times a day. 500 milligram is the medium regimen, 3 to 4 times a day. And the high regimen is 750 milligram 3 times per day. So you must very judiciously use your antihypertensive medication dosages with the proper segregation, identification, and not generally quickly go to the next antihypertensive, because this would help to not only ameliorate the complications, but help in prolonging the pregnancy in case it's a preterm preeclampsia. Now, effective has been proven safe in long term. Some studies suggested some benefits of labetalol, and doctors should definitely use what they find it familiar, and we learn that ACE, ARBs, and atenolol are not to use. Now, let's come to the milder version. Now, friends, we must remember that the moment you have a BP of 140/90, what we are seeing is only the tip of the iceberg. There are a lot of things that are happening under the surface in the mother's body, and it is going to affect the baby also. And therefore, the moment there is an abnormal blood pressure, we must start investigating. So if you look at mild blood pressure, which is spoken as 140/90 or 150/100, while moderate would be 150 to 159/100 to 109, it is important that we should look at the patient's comorbidities and symptoms and accordingly award her treatment. So a normal blood pressure in a pregnant woman should be always less than 140/90. I would also start paying a little attention to them when the BP becomes 130/80 or more. Mild to moderate, we know the ranges, and severe hypertension we have already studied. So the Foxy Gestosis certificate course in its HDP expert committee guideline mentions that considering the different international guidelines for treatment of hypertension pregnancy, it seems reasonable to conclude that a systolic blood pressure of more than or equal to 150 and a diastolic blood pressure of more than or equal to 100 warrants therapy. Now, so therefore, naturally, what do we do in the mild and the moderate version? Less clear maternal fetal benefits over the relatively short duration of a full-term pregnancy, lower maternal BP. We always have a fear that it will reduce the placental perfusion and expose the fetus to harmful effects of the medication. And then we had this particular CHIP study, the 2002 meta-regression analysis, which specially evaluated the effect of lowering maternal blood pressure on fetal weight and it was found that it was slightly but significantly lowered in association with lower MAP with antihypertensive therapy. A 10 milligrams mercury fall in mean arterial pressure was associated with a 176 grams decrease in the birth weight, and this effect was unrelated to the type of hypertension or choice of a medication. So the contrast was that 2015 CHIP trial that randomly assigned pregnant women with hypertension to diastolic blood pressure treatment targets of 85 or 100. Maternal treatment did not increase the risk of delivery of a small for gestational age infant or cause excess fetal risk. What happened further? They did a post hoc analysis, and where they found that severe maternal hypertension was associated with LBWs, preterm births, preeclampsia, HELLP syndrome, when women who were randomized to less tight control, who developed severe hypertension, had a higher rate of serious maternal morbidity. And this is that famous CHIPS study, which compared the tight control versus the less control in these particular patients. And it was found that the target blood pressure they always considered to be diastolic blood pressure less than mercury. And the CHIP study has mentioned that blood pressure of 140/90 mandates treatment and doesn't cause any significant problems to the baby, but will definitely protect the mother. Immediately following its footsteps, recently in the 2022 NEGM, we have the published paper, and this is on CHAP study, as we call it, wherein treating mild chronic hypertension in pregnancy reduced the adverse pregnancy outcomes without impairing fetal growth was what was concluded. So in this antihypertensive therapy for mild chronic hypertension improves pregnancy outcomes, a pragmatic multicenter RCT. And in this, they looked at composite morbidity in the mothers, any preeclampsia, hypertension or organ dysfunction or severe hypertension. And the preterm births and LBWs were studied in this particular study. And the key takeaways for the clinician were treatment of mild chronic hypertension during pregnancy to a BP goal of less than 140/90, reduces a composite of adverse pregnancy outcomes significantly and does not impair the fetal growth. Now, another patient is the one who has delivered, and now she's going to go home. So women whose pregnancies have been complicated by severe preeclampsia or eclampsia should be offered a formal postnatal review to discuss the events of the pregnancy. Preconceptional counseling should be offered where the events that occurred, any risk factors and any preventive therapies can be discussed. Very, very important. And the WHO guideline development group put more emphasis on the frequency of postpartum deaths related to stroke and recognized that the maximum increase in blood pressure usually occurs towards the end of the first postpartum week, when in most settings, women have been already discharged from the facility care. So initially, BP may fall, rises again around 24 hours postpartum. A reduction in antihypertensive therapy should be in a stepwise fashion. After preeclampsia, BP can take up to 3 months to return to normal. BP should not be allowed to be more than 160/110. Currently, there is insufficient evidence to recommend any antihypertensives. Avoid alpha-methyl-dopa as it has adverse effects such as maternal depression. And in breastfeeding women, labetalol, atenolol, nifedipine, and enalapril can be given singly or in combination. In women treated with antihypertensive drugs antenally, continued treatment is important. And treatment with antihypertensive drugs is recommended for severe postpartum hypertension. But you can see that there is very low quality evidence, but there is a strong recommendation based on the expertise. So some antihypertensive drugs.
Dr. Girija, may I interrupt?
I'm just about to finish, sir. Last one slide.
Okay.
So use of ACE inhibitors should be prevented, and then are they safe? All antihypertensive drugs cross the placenta. There's no RCT. Data regarding both comparative efficacy and improved pregnancy outcomes and fetal safety are inadequate. And therefore, uncertainty continues to be there to which antihypertensive can we choose. In agreement is methyl-dopa and labetalol are better. ACE, ARBs to be avoided. And chronic hypertension, we have to do an assessment and accordingly treat them. The areas of controversy, there is increasing debate regarding discouraging the use of diuretics And there's also controversy regarding the use of supplementation, such as calcium antioxidants and low-dose aspirin. So growing points are less restricted blood pressure goal in chronic hypertensives, healthy body weight before pregnancy, and recent guidelines also encourage women to keep their dietary sodium intake low, either by reducing or substituting sodium salt before pregnancy. So in conclusion, I would like to say be aggressive and be obsessive, because as I would like to quote Mother Teresa, we ourselves feel that what we are doing is just a drop in the ocean, but the ocean would be less because of that missing drop. Thank you so much, because at the end, we have to deliver healthy babies of healthy mothers. Thank you.
Thank you so much, Girija ma'am. I think Dr. Jitendra was unavailable for today's session. Gajja sir, would you like to conclude the session with your vast experience you have, sir?
Please unmute. Dr. Gajja sir, please unmute yourself.
Okay.
Unmute, yeah.
Yeah, I have already unmuted.
Hmm.
So it's a wonderful talk and a very big topic which you have tried to cover at your level best. Most important things are new onset intrapartum preeclampsia. Most of the patients who are coming to are outdoor with a normal blood pressure, and suddenly in the middle of the night she comes with a rise of blood pressure. You have very nicely covered the target values 150, 100, 140, 90. You have taken all the drugs, especially methyl dopa is not available in Gujarat. As in Maharashtra also, I have used methyl dopa in the past with a very good experience. Labetalol, nifedipine, we are using routinely. The most important thing that you have covered is the hypertensive crisis, because it has a very high mortality due to CV stop. And one more thing that you highlighted is the investigate a patient of chronic hypertension, systemic evaluation, and comorbidities, even preconceptional, and no AC inhibitors. Thank you, Dr. Girija. Thank you very much.
Thank you, Dr. Gajja sir, for being with us.
Yes, I think Dr. Gaurav wants to make some comments. I would just say, Girija, it was an excellent talk. What we usually talk about is the clinical aspects mainly, but your talk is always way forward and of course very research oriented. You always give some food to thought, so excellent. Over to you, Gaurav.
Right, madam, it was a very excellent talk. Only thing I want to ask is regarding labetalol. That initially and all textbooks, all guidelines, they say the dose is BD. But now suddenly ISSSP has started talking to use labetalol in 3 to 4 times a day. So can you throw a light on it?
The BID dose, if you look at the pharmacokinetics of labetalol, they are actually 6 to 8 hours is the peak, the duration which lasts, and the peak action comes within 40 minutes or so, 30 to 40 minutes. So it will keep acting for 6 to 8 hours, and that could be the reason why they must have shifted from the BID dose to an 8-hourly dosages.
Right, but still no guideline except the ISSSP.
Anti-hypertensive medicines, unfortunately, there are no guidelines for anything. We are using a lot of things arbitrarily based on our experience, based on the patient's condition. And therefore, there is nothing sticking out to say that this is better than that is better. What my contention is, please use them promptly, one, and use them in the right dose. Tumhara frequency, I understand what you're trying to say, Gaurav, because one of the components of dosing is the frequency of a drug. So that you will have to help by taking into account the continuous monitoring and then take a call as to what's going to be best for your patient.
Right, because using labetalol 4 times a day will be very dangerous, because it will cause a tremendous tachycardia.
Yes, and I must tell you that in whatever my experience is there, I have always used only a BID dose quite effectively, and I've been happy with it.
Perfectly said, ma'am. So now, without further ado, we are already running late. I would invite Gorakh sir and Sneha madam for the panel discussion, most awaited session, brainstorming.
Yeah, Archana, please don't introduce. We straightway go ahead with the panel discussion. You can stop sharing. First of all, I would like to thank everyone, and now welcome dear Dr. Gaurav Mandrukar, who is, who has been doing his work extensively in the field of SDP justices, and I would just like to invite and welcome him and just as introduction, I would like to say that he was the chairperson of Medical Disorders Committee for FOXI, and he's the chairperson of the SOP and Guidelines Committee of AMOX, and HDP Justice's core, that is his, discovery, I would say. So he will throw light during the discussion. Dr. Girija has extensively discussed the theoretical aspect and the research way forward. We are going to have some panel discussion, which is, of clinical aspect, and it will be helpful to all of you in the day-to-day practice. So Gorak, anything in the introduction you would like to say? I would like to just welcome the panelists. Dr. Mukesh Patel, Dr. Shilpi Rawal, Dr. Ankita Jain, Dr. Runda Suprit Bhatt, Dr. Paresh Parmar, Dr. Dhaval, and Dr. Pinky Kataria.
So welcome all the panelists, and Madam Sneha, thank you very much for involving me, and I wish the great success in your endeavor, and I think we all should be with her, because she's such a great academician, and she's working in the field of these medical disorders in so many years. As Madam has rightly pointed out, that women are dying not because of the disease, and we cannot treat, but because societies have yet to make the decision that their lives are worth saving. In fact, we all are working with the saying, say that every single mother should be saved. And I think we all know that hypertension, hemorrhage, and sepsis, they are the major killers. And if we predict them, if we prevent them, and yes, despite that, if the disease occurs, if we are really prepared, then that is really key to the success. And though, as rightly said by the sir, that yes, whether we are in search of any good predicting markers, I think the careful history taking itself and the clinical factors, we should not say ourselves as a third world country. India is, yes, it is. Modi ji has shown that India is at par to the world, any other country. But if you see the guidelines of American task force, even they have said that predicting the biomarkers with the usage of biomarkers like PLGF with PAPE, and even with the uterine artery Doppler and all, it is just not possible even for US, because they are very much expensive. So it is sincere urge to all of you that please use Justosis score, please use careful history, and yes, as Madam has rightly said, or even shown in this slide, that yes, if it is possible, you can use those biomarkers, but not for all. But if we use in a correct dosages, high dose calcium, vitamin D, low dose aspirin, again 75 milligram at bedtime a day, definitely it is going to prevent all of these things. And still, if anything goes wrong, then what happens and how to manage it, we are going to brainstorm in this panel. And we all know regarding all this pathogenesis and whatnot. And now Dr. Sneha Bhuyar, she will take the lead in each case. And then later on, I will be helping her in commenting in this panel discussion. So
Yes.
over to you, Sneha, madam.
Thank you so much, Dr. Gorak. And we would like to start with our first panelist, Dr. Mukesh Patel. Is Dr. Mukesh Patel here? Archana, can you help us? Hello? Hello? Is Dr. Mukesh Patel here?
Okay, anybody else in the panel can take
Anybody from the panel?
Can take the case. This is
Yes.
a case that
So we
22-year
have
primary
this, 22-year-old primary gravida belonging to a low socioeconomic status, and she has no known medical illness, no significant family history, antenatally booked, and she has had uneventful post till now. She presents to you at 32 weeks of gestation with blood pressure of 140/90 millimeter of mercury, which is recorded at the OPD. So how should we manage this case? Anybody from the panel, we can make this open. Yes, I can see Dr. Ankita, Dr. Shilpi. Yes, all of you are here. All of you can please unmute yourself.
I have already unmuted, ma'am.
Yes. So what will be your way of management? How would you manage this patient? Or whether on domiciliary basis, whether you would like to hospitalize her? Would you like to start her on antihypertensives? How would you go ahead? Dr. Ankita, we can't hear you. Your audio is off, I think. Yes, Madam Shilpi Raval, whether you want to comment on this?
Yes, ma'am. I would like to measure her BP at least 6 hours apart before stamping her having preeclampsia. I would like to go for blood serological investigations.
Correct.
Then color Doppler sonography also.
Madam, what investigations you would like to do her at this point of time?
Complete blood count, platelet count, then liver function test, renal function test, then urine examination for proteinuria, then serum uric acid, especially in renal function test, serum creatinine. Then fundoscopy examination also.
Yes. Suppose you find that she's got mild thrombocytopenia and she's got impaired liver enzymes. Then whether you would like to categorize her as severe or is she still a mild hypertension?
If she's having mild,
rather I would say whether you would like to look for any features of severe hypertension. And what are they?
See, if she is having any complaint of like headache or disturbances in vision, or if she is having proteinuria, I will stamp it as a, if proteinuria is, severity of proteinuria matters.
Okay. What else you would like to do for this patient? Whether you'd like to hospitalize her once you label her as severe hypertension?
No, this is not a kind of severe hypertension. So, okay, we can treat her at home and we can advise regarding the close follow-up and repeated.
Madam, just now you said that you would like to look for all these features which are suggestive of severity of the hypertension. And you also said that you will go for blood investigation. So if you find the liver enzymes impaired or the renal parameters impaired, so would you like to label her as severe or non-severe?
Severe.
So whether you would like to hospitalize her?
Hospitalize, definitely.
Yes. Okay, madam. So now the next question comes to you, Dr. Ankita. Whether you would like to start her on antihypertensives at this blood pressure? No, we can't hear you, Dr. Ankita. Can you please adjust your audio? Dr. Vrinda, Dr. Ankita, your device audio is low. You can adjust with that. Yes, Dr. Vrinda.
Unmute Ankita.
Dr. Vrinda?
Okay. So yes, I would like to start because the patient, apart from having blood pressure of 140/90, which stands for mild preeclampsia, but she has other symptoms of severe preeclampsia like elevated liver enzymes or thrombocytopenia. Then I would like to definitely admit her and start her with the antihypertensives.
So whether you would like to name her or recategorize as severe hypertension. Yes, previously you said it was non-severe hypertension.
But after the
so the concept has changed from mild, moderate, severe to severe and non-severe. Okay.
Yes.
Okay. So whether you would like to start her on antihypertensives, that question still remains.
Yes, I would like to start her with antihypertensive.
Which one now? And how much?
Labetalol is the primary drug of choice, which I use in my practice. Labetalol, I would like to start her with labetalol, 100 milligram orally initially, and then
what dosage, what frequency?
At 8 hourly. I usually prescribe 8 hourly.
Okay, so whether you would initially start with 8 hourly or you start twice a day and then you try and titrate it. 140/90, you want to start. Gorakh, whether you want to make any comment here?
Actually, now one thing we all are on the same line. Only thing one must understand that it is not only the blood pressure, but the severity depends upon the lab
Other
parameters as
factors,
well.
proteinuria.
Or even forget about the proteinuria, because all the guidelines, let it be US guideline, Indian guideline, WHO, they all have taken the importance of the proteinuria. So it was a traditional teaching when we were used to fear 2 plus proteinuria section karo, 3 plus proteinuria, forget about it. Once there is proteinuria, it indicates that yes, whether it is preeclampsia or not. Number one. Second thing, as you have rightly pointed out, definitely you will start the antihypertensive. Only the thing is, the guideline says that better to start initially 100 milligram BD and then slowly titrate the dose and increase it slowly by 100 or 150 daily. You have to add on. Again, as Madam Shilpi has said, yes, she would like to monitor the patient very carefully because this patient has thrombocytopenia and even impaired liver enzymes. So probably the patient might be going either one in a severe case or it might be the initial phase of HELP syndrome. So we have to be very careful because it is deterioration. As Dr. Girija Wagh has rightly said, pointed out, it is the severity of the blood pressure which will be seen not only by the measurement of blood pressure, but by the derangements. So we have to start the antihypertensive. Initially, olden days, we used to say that we have to start at 150, 100. But nowadays we are saying no, we have to start at 140, 90.
Yes.
In fact, the very recent ISSSP says that we have to start at 135, 85.
Yes.
But still, our Indian guideline, we are accepting at FOXI, at ICOG. Madam was chairman at Medical Disorder Committee at AMOGS. Still, we are saying that 140, 90, we have to start antihypertensive, and that is the right message. Here, I would like to give last suggestion. If the pulse of the patient, if it is 100 or more than that, then I think, as Brunda Madam has said, right, your first choice should be labetalol. But if the pulse of the patient is, say, towards bradycardia, maybe 70 to 80, probably nifedipine will be the choice. So that we have to keep in mind. We have to individualize the decision of starting the antihypertensive and should not stick, okay, this is first line or that is first line. So I think that we have to be careful.
So very rightly discussed, Dr. Gorak, that you have to initially the guidelines said that 150, 100, but now the guidelines, especially the World Justice guidelines, say that we have to start it at 140, 90. And of course, what you said, how to decide between the two antihypertensives. If you have tachycardia, edema, and persistent headaches, better to avoid nifedipine and then go for labetalol. But if the patient has bradycardia and maybe asthma also, then we have to avoid labetalol. That is how you have to choose between the two. The dosage, very rightly, he has discussed already. So why labetalol? That also he has already discussed, that it is very safe. It gives you very consistent reduction in the blood pressure. It maintains it steadily, and of course, it doesn't interfere with the placental and fetal circulation. So this is all theoretical. I would just ask you, why not alpha-methyl-dopa? So Ankita, are you on? Dr. Pinky,
somebody said that yes, we have lost the opportunity.
Yes,
alpha-methyl-dopa has gone. But now can somebody say why not with alpha-methyl-dopa? How the newer drugs like labetalol and nifedipine are better than alpha-dopa? Can anybody throw a light on it, please? Dr. Pinky?
Yeah, Dr. Pinky, are you here? Or Dr. Ankita, we can see you unmute.
Yes, hello, am I audible?
Yes, perfect.
Exactly. Right. So mainly the side effects of postpartum depression is one what we stopped using this drug, and also the headache profile, which also happens with nifedipine. But since the very good and safe option of labetalol was available and the side effect profile of this was not acceptable, hence we, have stopped using M-dopa since a long time.
Anything else? If you have you know, practically you must have observed, you know, these patients, basically, if the patient has hypertension, it took at least 24 hours for its, you know, onset of action. That was one factor which was really prohibitory. And also the presence of orthostatic or postural hypertension and the galactorrhea, sometimes, you know, the postpartum sedation, which used to interfere with the breastfeeding. These were all the causes. Yes.
Yeah, even postural hypotension was a bad side effect of these drugs because, as Madam, you have rightly said, we had to increase the dose of the the alpha dopa, like from 250 to 500 TDS. And when it crosses 1.5, there was a great side effect of postural hypotension. And as Madam Ankita has said, yes, postpartum blues, postpartum depression was very common. And that's why suddenly after the delivery, we had to change the drug to another drug. So yes, now it has gone fine. But whatever available, nifedipine and alpha dopa, the labetalol, they are fantastic. Over to you.
Yes. So just to discuss, Dr. Mukesh Patel, I don't see him here, but anybody can take up. What is the, where do we advise strict bed rest to the patient, and should we advise salt restriction? Yes, Madam Shilpi, you can take up this question.
Complete bed rest is not required. Patient can do her routine work.
In fact, it is hazardous. In fact, it is hazardous, yes. So,
And
in fact, thromboembolism, the risk increases. Okay.
And she can take the basic food with less salt, but not complete salt restriction is advisable.
Correct.
Right.
Correct.
Madam, may I ask here what is the practice in Gujarat? Okay, whether overall we are advising them for the salt restriction or what we are advising them in Gujarat? What is the practice?
Actually, they should not add extra salt because they used to adding extra salt to their plates. So strictly we avoid using papad and that pickles and everything. We have to instruct them properly.
Right. Vrindaji, you were saying something about a sweet.
Yes, we advise the patients that they should avoid using table salt for anything over and above their routine.
Right.
So,
here I would like to.
And we also focus on that the patient should be, from beginning of the second trimester, they should be advised or encouraged for exercise or walking, which will also be helpful.
Excellent. Here I would like to focus one thing, that when we are advising or when we are talking with the patient regarding the diet, we should tell her three things. Okay, no need of restriction of the salt, but no added salt.
Yes, avoid extra
Restrict your carbohydrates. They should restrict the carbohydrates and they should eat high protein diet.
High protein diet.
So if the three things they do, definitely the incidence will go down. Regarding the exercise, we should tell them, yes, you can do whatever you want. Only thing, no excessive exercise.
Yes.
Because you are pregnant and there is blood pressure, but no bed rest at all. But here again, we have to inform them if they walk or if they do the exercise, there will be excessive edema. So don't worry about it. Just take a pillow below the legs and it will vanish. Otherwise, they have a great fear about the edema in their mind. So we have to tell the balanced advice regarding the diet as well as the exercise.
Yes.
So regarding the edema,
yes.
So we take So
regarding the
we take this
edema-
case ahead. Yeah. Somebody wants to say
Yeah,
something.
Dr. Ankita wants to say something.
Yes,
edema
please.
is a very common finding in the later months of pregnancy because of the
Yes.
increased blood volume, and it
Yes.
comes earlier in patients who are high risk for preeclampsia
Yes,
or
absolutely.
hypertensive.
Yes.
And that's the only complaint, that I have leg swelling. You have checked, there are no
Because of the dependency and also the vena cava compression, also you can have edema because
So
of
it
the
is better-
stasis in the lower limbs.
So it is
So
better
not
to
to
tell,
worry about it.
and it is better to tell the patient कि पिलो के पोजीशन बदलो, सर के नीचे से लेके पैर के पीछे डाल दो, बस काम हो गया.
So in the evening, it's in the legs. In the morning, it's in the face. The fluid will be somewhere in the body. I tell them this will go away after your delivery. Don't
Correct.
panic about your
Yes.
edema right now.
Fantastic.
There is no drug, no exercise that will reduce your edema during pregnancy if you have already developed it.
Great.
So they're like, if I walk, my feet pain. I'm like, it's okay, but you have to do it.
Absolutely. Fantastic.
So I think Gorak, we take this discussion ahead. This obstetrician who managed this case, she was from the previous generation and she was not aware of this modern obstetrics. So she thought it's a mild hypertension. She sent her home. And after a few days, this lady, she was brought to the hospital with complaints of severe headache, nausea, upper abdominal pain. When you examined, her BP was 170, 110, and her reflexes were brisk. So now what is the diagnosis of this patient and how will you manage? Madam Shilpi, you can take up this.
Yeah, this is signs and symptoms of impending eclampsia. So we should give her the magnesium sulfate in a full dose. And she should be given IV antihypertensive drug to control her blood pressure.
Correct.
We have to admit her in ICU condition, keeping everything ready, monitoring and oxygen and everything ready. We have to inform in case of emergency. We have to inform the anesthetist, the pediatrician for the help. And we have to send.
Okay, so madam, yeah. You have given her, you have hospitalized her, given her antihypertensives and prophylactic magnesium sulfate. Would you like to investigate her to categorize whether she belongs to this hypertensive urgency or emergency, and how fast you want to bring down the blood pressure, and what should be your optimum blood pressure? What should be the blood pressure maintained at?
She should have that blood pressure gradually. It should come down. Not a very fast drop in the blood pressure, but I would like to maintain her blood pressure within the range of 140, 150 systolic and 90, 100 diastolic. And I would like to send the blood investigations for her. What I have previously told, the CBC, platelet, and
all the investigations.
All the investigations. Then ophthalmic fundoscopy.
Madam, how does it affect your way of management? Suppose the BP is very high, but the investigations are normal. Now, what is your plan of management?
See, we have to see the gestational age at which the patient can. If it is less gestational age, we would like to pull on the pregnancy till the baby is mature. So it matters.
Correct. Suppose you have this severe hypertension and her investigations are showing impairment in renal function, or maybe liver enzymes are significantly elevated. Then how would you manage her?
Actually, we have to terminate the pregnancy.
That is what. How would you take the decision? The end organ damage. That is what. To be considered to decide the management.
Right.
So, Gorak, you want to add something here?
Right here, Madam has rightly pointed out, Shilpi Madam, we have to take the blood pressure down. No doubt. It has to be promptly, but again we have to keep in mind that fetus is still inside the body.
Yes.
So the mother may develop abruption, or there can be sudden IUD. So it has to come in a proper way. But at the same time, when you are asking when blood pressure, when the investigations are normal, but still there is high blood pressure, and then probably we have to terminate the pregnancy, but we should not make a hurry to terminate the pregnancy.
Yes.
Because first we have to stabilize the mother. Because again, if we have not stabilized the mother, then we are digging a grave for us and for her as well. Yes. So that we have to keep in mind. We have to keep her in a proper monitoring. We have to use injectable drugs like injectable labetalol. If it is not available, injectable labetalol is not available, or you do not have the facility of ICU, but still you want to control the blood pressure, then the best drug is nifedipine. Here, you should not use the slow preparation. Here, you should not use sublingual. But here, you have to use nifedipine tablet form. And we can start with 10 to 20 milligram every 15 minutes, looking her blood pressure. We can reach up to 60 milligram, start the Maxil, give as you have rightly said, give the first dose of the Maxil and ship the patient where the facilities are available. And there they will take care of. So it is what madam is asking is the decision of us whether I can manage the patient at my place, manage. If you not, give the first dose of everything. The first dose of antihypertensive, first dose of magnesium sulfate, first dose of steroid even.
Perfect.
IV cannula and shift the patient. Because that is the management. Because what we are expecting here, हर एक मदर को बचाना है.
Yes.
तो पहले ये सब दे दो and भागो patient को. So if we transfer the baby with a good incubator, that means the abdomen, the uterus. Then probably we can save the mother as well as the baby, both. So that is what we want to come out with this panel discussion.
Yes.
So anybody would like to, but Madam Vrundaji,
you can add something.
Labetalol regimen, what you are using at your place.
Yes, Dr. Vrunda. How are you using labetalol intravenous?
In your place?
In IV, we start with 20 milligram diluted dose, given very slowly over 2 to 3 minutes.
Correct.
And then we will repeat the blood pressure measurement again every 10 to 15 minutes. And then according to the blood pressure, we can increase the dose. And if at
So if it doesn't come down within 10 minutes, then you have to increase the dosage to 40. Yes.
Increase the dose to 40, then we can again increase the dose to 80, but not giving more than 220 milligram.
Yes, 300 milligrams.
So can anybody tell how to avoid the overdosage of the labetalol? Can anybody tell? Ankita?
Avoid overdosage.
Yes. कि कैसे, क्योंकि डॉक्टर वृंदा ने तो सही बताया कि 300 के आगे तो नहीं जाना है, तो कैसे करें हम 1 मिनट में? चलिए सिंपल आइडिया बता दूं. राइट. तो पहले से 300 मिलीग्राम बना के रखो. एक बार आपने बना के रख दिया तो उसी में से 20 लेना है, देना है, उसी में से 20 देना है, लेना है, उसी में से 40 देना है, उसी में से 80 देना है. एक बार 300 खत्म हो गया तो बस भगवान के फोटो और अगरबत्ती, बाकी कोई नहीं बचा सकता. तो एक बार 300 मिलीग्राम बना के रखो तो कभी हम ओवरडोसेज नहीं देंगे. अदरवाइज इट बिकम्स वेरी हेडेक कि अरे फिर अभी 20 दिया था, फिर अभी क्या करें. इससे अच्छा है 300 बनाओ, उसी में से 20, 40, 80 बस खत्म. इससे आगे तो कुछ नहीं कर सकते. तो लाइकवाइज वी हैव टू मेक. तो एक बार पहले से हम हाई डोज बना के रखें, देन वी नेवर मेक अ मिस्टेक.
So all very practical tips given by Dr. Gorakh. Madam, I think you have already said about prophylactic Maxalt. So how much magnesium sulfate and which regime are you using?
Anybody, please throw light on
Dr. Vrunda, Dr. Ankita, I think I will ask you.
We are using the intravenous regimen of Maxalt. Since she is anyways
Which
32,
regime?
The Sibai, the 4 grams.
Sibai or Zuspan?
Sorry, Zuspan, the IV regimen. IV regimen Zuspan.
Okay.
4 grams we are giving IV loading dose over 20 minutes, and then 1 gram per hour for till 24 hours of the last seizure or postpartum, whichever is later. And in books they mention 1 to 2 gram per hour, but I have so far been giving only 1 gram per hour.
1 gram per hour.
When you utter Zuspan, it is 1 gram. When you utter Sibai, it is still 1 gram.
And of course, we keep a watch on the knee-jerk reflexes, the urine output, the respiratory rate. If possible, and if you're suspecting magnesium toxicity, then we can check magnesium levels. If magnesium toxicity has occurred, then of course we can stop the maintenance dose, but the loading dose has to be given. So
I don't think we should wait for the toxicity. We should keep continuously monitoring the respiratory rate and the reflexes and the urine output. So if the respiratory is either very low or the reflexes are not elicitable, or even the urine output is less than 30 ml per hour, we should withhold that dose.
May I ask here कि सबसे पहले क्या जाएगा? सबसे पहले क्या जाएगा? रिफ्लेक्स जाएगा.
Yes, tendon
तो
reflex.
जैसे रिफ्लेक्स जाता है we have to stop, और जैसे रिफ्लेक्स वापस आता है we have to start.
Yes.
And that too in a half percentage. ये ध्यान में रखना है. That's it.
So
Otherwise, कभी वो Maxel बंद नहीं करना है.
हाँ,
जैसे
don't
हमने
wait
का
for the
request दिया-
toxicity and don't wait for the reports of magnesium levels to come.
Absolutely.
It's a clinical assessment that we have to work as
Ankita,
there and there.
Yes, I'm sorry to interrupt. Ankita, आपने बोला कि you are using IV regimen, right?
Yes.
तो आप कैसे देते हो? आप 1 gram per hour कैसे देते हो?
Yeah, we take 500 ml saline and put
5 grams.
10 gram, 10 ampules in it. 1 minute.
So आप उसमें 10 डालते हो?
10 ampules in 500 ml and given at 50 ml per hour. So that is 1
What
gram.
percent? What percentage of Maxelf you are using?
1 gram and 2 ml, half.
No. Maxelf ampoules, weight by weight.
1 gram and 2 ml. 1 gram and 2 ml of ampule.
Yes, so 1 ampule is 1 gram.
Yes.
You want to put 5 grams in 500 ml, then only it will go as 100 ml per hour or 1 gram per hour.
No, but
So I'm
what they are
doing
doing
50
is
ml per
again,
hour.
yes. Again here
10
I want
ampules in 500.
yes.
So
Again
that we
here
give
I
less
want-
fluid.
Okay.
Because if
Again
otherwise-
here I would like to say something. Please, everybody, please listen. That now there are good magnesium sulfate, small 100 ml bottles are available, and if we use them, they are like anything because they are 50%
Yes.
weight by volume. So one thing we have to keep in mind, we should never exceed IV fluid than 80 ml per hour. आपका जो रेजिमेंट है उसमें भी आप 50 ml per hour दे रहे हो, तो अगर बाकी कुछ IV देना पड़ा तो इट विल एक्सेस. सो इससे अच्छा है कि दूसरा छोटा कौन सा यूज करें. तो ये जो नया वाला आया है, इट इज वेरी इजी. तो पूरे 24 आवर्स में सिर्फ 6 जाएंगे, 4 या 6 जाएंगे. So that means only 500 ml is going. Overall fluid in 24 hours, only 500 ml is going. So it is sincere request to all of you, those who are looking this webinar, that we want to tell all of you that please use those IV bottles of magnesium sulfate. It will be with good concentration. It will give the less fluid to the patient, and it is easy to remember as well कि बस ये 5 या 24 आवर्स में दे रहे हैं. और उसी के अकॉर्डिंगली अगर हमने हमारा IV फ्लूइड का ड्रिप रेट अच्छी तरह से एडजस्ट किया तो डेफिनेटली इट विल बेनिफिट लाइक एनीथिंग. और इसे टॉक्सिसिटी से भी बचने का एक अच्छा आसान ये तरीका है. In AMOGS, through Madam's committee and my committee, we are coming out with a very good initiative, that is zero eclampsia by 2025 in Maharashtra. So Dr. Shilpi Madam, Dr. Ankita Madam here is there, Dr. Vrinda, all of the seniors, because Dr. Alpesh is here. Next year he is taking over as a chairman of Justosis India. So I urge that even Gujarat should take hand with us and start this thing, zero eclampsia in Gujarat by 2025. So this is simple initiative where we use this IV regimen of Maxel. Over to you, madam.
Yes. So, friends, we have this patient who has presented to us as very severe hypertension with impending eclampsia. So our first aim is to stabilize her, take care of the mother. So give antihypertensives which are injectable. We have decided either labetalol IV or oral nifedipine. And then we give her prophylactic magnesium sulfate, which is only to say prophylactic, but the dosage is exactly the same as therapeutic. So pre-charge Maxelf regime, which is the preferred one we have been using over the years, and now, as all of us have discussed, the IV Maxelf regime, which we are giving it as infusion. So 1 gram per hour, that should be the IV infusion, and it will also help in reducing the fluid intake. So we stabilize the mother first. We now start evaluating the fetus. And we want to take this pregnancy ahead because if there is no end organ damage, we have to pull on the pregnancy. If there is a end organ damage, of course, we have to terminate this pregnancy. But before that, we prepare the fetus by giving steroids, that is injectable betnosol or dexamethasone. Now the time comes here that you have stabilized this mother, the fetus is also well. So what are the end points where you may have to, warrant termination of this pregnancy? You have pulled on maybe to 32, 33 weeks. We want to take it to at least 34 weeks. So meanwhile, what are the things, what are the symptoms or signs you want to, look for that needs or warrants termination? Anybody can take up.
Changes of end organ damage.
Yes.
Fetal Doppler. If there are any, if it is showing absent or reverse diastolic flow, God forbid, then we have to intervene early.
Correct.
Worsening condition of the mother, blood pressure that is not being controlled.
Yes.
Proteinuria increasing.
Proteinuria is not a measure for severity. Even fetal growth restriction is not considered as the measure of severity. But as you have rightly said, yes, development of either HELP syndrome or acute renal failure, eclampsia or abruptio placentae, these are the maternal indications which warrant termination of pregnancy. And as you rightly pointed out, the Doppler parameters, if they show absent or reversal of end diastolic flow. So, what is, we have already discussed this role of prophylactic magnesium sulfate.
Here I would like to add one line that
yes,
whatever
yes.
regime you use, either you use Zuspan or Prechat, even in prevention as well, we have to use the regimen for all 24 hours.
Yes.
It is not like that for prevention only loading dose de diya or band ho gaya. No, we have to use full regimen.
Yes, that is what the message. That is what the message. Even I said, and good that Gorakh, we are stressing on the important points, both of us, that even though it is called as prophylactic, the dosage and the schedule, entire schedule for 24 hours after the last convulsions or delivery, whichever is later, is the same. So it is just to say it is prophylactic because the patient has not yet convulsed. That is what is the prophylaxis for eclampsia. But the dosage and the regime is exactly the same as therapeutic. So this patient, when you said that she was having severe hypertension, headache, pain in abdomen, suddenly you when you examine, you find that her uterus is tense, tender, and her blood pressure is 170, 110. Fetal heart is going down to 110, 120. And when you examine her to evaluate for delivery, you find that she's got fresh bleeding and the horse is 2 centimeters dilated. What is the complication that has happened here? How do you confirm this and what investigations you want to do? Dr. Vrinda or Dr. Ankita, Dr. Shilpi, anybody can take it. Yeah.
Yes. Case of abruptio placenta.
Okay, so how would you confirm?
So of course, clinical signs and symptoms are suggestive of abruption, and apart from that, we can confirm it by some ultrasonography. That is another tool.
Yes, yes.
That can confirm the.
And whether it is only abruptio placentae or whether it is associated with DIC, how do we confirm that?
Then we need to do all the parameters of profile, like thrombin
coagulation profile.
Coagulation profile has to be done. Serum fibrinogen, fibronectin level should be checked.
Okay. So this patient had impaired parameters. So she was also in DIC, and of course, when you need operative interventions, then what all things you should keep ready and what anesthesia, this is all the matter of discussion. So whether you want to throw some light on this. If you have a patient of abruptio placentae with fetal distress, whether you will do the Caesar first or you will arrange for blood and blood component first, how would you go ahead?
I will arrange for blood and blood components, and simultaneously I will prepare for.
Yes. The only one word message here, everything has to be done simultaneously and as emergency. So just a last point, and then we conclude, I think. This patient who was having, persistent headache, even after seizure, she had a persistent headache. She was not relieved of this. And when the MRI was done, she was found to have this white matter. She was found to have this high signal intensity bilaterally, and she was having this vasogenic edema. So she was a case of PRACE, posterior reversible encephalopathy syndrome, which she has landed up into. So I think any additional message you want to give, Gaurav, then we will conclude.
No, thank you, all of you. And Madam Sneha, I'm very much thankful that you have included me in this. And all the panelists, Silpi Madam, Dr. Bunda, Dr. Ankita, and all of us, really, they were given good messages. And here I would like to give just 4 or 5 lines. Number 1, please take a proper clinical history. Please download the HDP Gestosis Score app from the Android App Store. Very beautiful. It's free of cost for the prediction of preeclampsia. Second thing, please use 75 milligram aspirin at bedtime, along with 1 to 1.5 gram of the calcium, high protein diet, low carbohydrate diet, low salt. Third thing, whenever we smell or whenever your patient says कि कुछ हो रहा है लेकिन मुझे समझ नहीं रहा है, she is a patient, she is going to worse, she can become worse at any time. So we have to be very much prompt, we have to very much neat in the writing all the things. We have to understand the importance of medical legal things in the prediction, in the prevention, as well as in the management of all such hypertensive disorder patients. And always keep in mind that still the baby is in the womb of the mother. So while using antihypertensive, we have to use the correct drug, the correct dosages, and the correct frequency. And magnesium sulfate for all antihypertensive mothers. I request Dr. Suchitra Pandit, Madam, she's still there.
I was about to say that.
Yes, to please give the.
Yes. Yeah, madam, I just saw you and I was about to request you for your words of wisdom. Madam, you are the authority for this field. So please, yeah.
Switched off the video, but I was listening to the whole thing. No. Excellent panel discussion and very good points suggested by both you and Gorak. I'd like to say that now there's a company, Blisson, which has come on with the Ready IV Mag Pack.
Yes.
Which is
100 ml. Yeah.
Yes. And they're currently available in Maharashtra and they're available in Delhi. So I have told them that they should move on to Gujarat as well as the South India. They're now trying to branch out. But this is something which is excellent. Nobody has to break their heads about 25%, 50%. Just use that. But just use whatever Maxel you're using, use it correctly. But look out for this. I'm sure, more and more people, when they start using, Blisson is going to start producing it even and making it even for Gujarat. But otherwise, no, I think the panel was excellent. The take-home points were very good. But just I'd like to tell everybody that, we have to do things practically. So those eclampsia drills, keep doing them if you're working in public hospitals or wherever. Keep doing them and train your staff. The staff should know exactly what to do when. And that is something which will help us. It comes by practice and it will help you definitely. Otherwise, congratulations, Sneha. Very well conducted program. And thank you for all your inputs. And of course, we all hope that you will come out with flying colors. We are sure you will for the.
Thank you. Thank you.
So all the Gujarat societies, please make sure that you all have voted and vote for Sneha. Thank you.
Thank you, madam.
Thank you so much, madam. All of us are, trying very hard to prevent the deaths related to hypertensive disorders of pregnancy. And as initially I said that we can predict, as all of us are saying, that history itself, the maternal characteristics, so many biophysical and biochemical markers are there. Only we need to follow all of them and we need to predict, try and learn to predict. though it is not completely preventable, we can definitely prevent or minimize the complications associated with hypertensive disorders, and thereby we can reduce the incidence of eclampsia and the associated severe morbidities and mortality. We should be able to save our mothers. That's the only aim. I think that's the only expectations for all of us as healthcare providers. We should take the responsibility. And with this, I thank all of you, and over to you, Kirtan and Archana, for the official vote of thanks. Thank you so much, Gaurav, for being the part of this program.
Yeah.
Yes,
Thank you.
Archana.
Thank you so much, ma'am, for making myself and Kirtan also a part of this program, because it has been a great learning experience. And as Suchitra madam has already said, it's my aunt's request to all the presidents and secretaries and the delegates, do vote. Basically, we lack to participate in voting. That is why the right candidature sometimes has to suffer. So let us unite together and support Sneha ma'am for her future endeavors, because we all will be benefited by the knowledge and dedication over decades what she has been sharing with us. And as myself and Kirtan are a part of a journey, we are sure that it will be a great future ahead. And vote of thanks is something which is really from my heart. I was really happy to hear Dr. Suchitra Pandit madam, Dr. Girija Wagh madam, and Dr. Kuldeep sir, and all the faculties who joined us, especially AMOX President Dr. Pardesi sir, Dr. Suchita ma'am, and we had ICOG Credit Point also associated to this. Munjal couldn't join us, but we know he is a hardworking man, has been a backbone behind that. And our delegates, Sneha madam, obviously it's a thanksgiving to you as well for sharing us with such immense knowledge and bringing such good
Pleasure.
faculties to us. Saiti and her Shield team had been a great platform to us, and निर्विघ्न जिसको बोलते हैं, एकदम अच्छे से आपने पूरा हमारा साथ दिया, and the things were very smoothened out. Thank you, delegates, for the patient hearing. Having Dr. Rishikesh Pai sir with us and he joined us from the Cape Town while boarding, was a great effort from his side. That shows his dedication towards the maternal mortality to be reduced, especially because of the hypertensive this thing. Thank you, presidents and secretaries, for being with us all the time. Some of you were abroad and out of the town and still joined us. We are really thankful to that. Thank you, everybody. Signing off for this evening, for looking forward to the few more episodes of knowledge and dedication.
We'll be
Thank you so
continuing
much.
this series, and definitely we'll be having few more societies in coming next 1 or 2 weeks, I think. Thank you so much. And once again, I thank all of you, all the respected seniors and president secretaries of all the societies
very
of
much.
Ahmedabad, Anand, Nadia, and Sari. And I urge once again to nominate me. The process is going on, and of course, vote for me as Vice President Foxy for the upcoming elections. Thank you so much. Thank you, Suchita madam.
Our best wishes always, madam.
Kirtan.